Hello, hello, check. Hello, 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 check.
Invite Dr. Suman Kanungos, sir, Director of ICMR RMRC, to deliver the welcome address. Sir, please take your time.
Thank you. Respected dignitaries, experts, students, and friends, I, on behalf of ICMR Regional Medical Research Center, Dibrugarh, welcome you to this two-day workshop on capacity building in research methodology for health professionals and researchers from Northeast region for undertaking quality health research for diseases of national and regional priority, scheduled for today and tomorrow. We feel honored and privileged to host you at this important workshop to enhance the capacity to conduct quality research in this region. This will enable us to increase the robustness of the data generated from this region, which will ultimately help in policy translation. This workshop, as mentioned earlier, is being organized under the Ayushman Bharat Health Infrastructure Mission, PMAVIM. The two-day workshop will be addressed by experts of national and international repute. Again, I welcome you all, and we feel honored, especially and fortunate to have our mentor and guide, the Secretary to the Department of I'm extremely sorry for this interruption. As you know, there is a power supply problem and there are some weather issues going on here. Where I was, we are honored and fortunate to have with us our mentor and guide, the Secretary to the Department of Health Research, Government of India, and Director General, Indian Council of Medical Research, Rajiv Bell sir, who has kindly agreed to address us, whose presence will provide tremendous impetus in this workshop. We also feel honored to be blessed by Additional Director General of ICMR, Dr. Sangamitra Prati, and Senior Director General, Dr. Manisha Saxena ma'am. We thank you for your agreeing to be part of the workshop. We also welcome Dr. Lakshmi Narayan, Deputy Director General Administration, Indian Council of Medical Research, for his presence. Again, I welcome you all. Now, thank you. Now, we are all eager to hear from you, sir. It's over to you, sir. Thank you. We are actually we are waiting for DG sir to join. He has already joined, sir, and let's we'll hear from him. Then we'll inaugurate the thing. তখন আরেকবার বলবো।
Recording in progress.
good science. Anything without good methods is poor science. Similarly, anything without not understanding the research methodology and following the research methods, implementing it in such a way that the research methods are followed is key to making any good research project. When I see you together, a lot of you and some very good people who will be talking about the research methods. I can see you will have, if, I'm not sure if Dr. Pati is there, but Dr. R.M. Pandey, Dr. Vishwajit Kumar, Dr. Sangamitra Pati, Dr. Subarna, Dr. Prem Moni, Dr. Nalin Mehta, Dr. S. Panda. All of them are excellent scientists who also have a very good sense of what the research methods they are following. So it is my sincere hope that who all are attending this workshop will make the most of it. I want to give only one more message, and that is that if you just attend this workshop, you will not learn much, let me tell you. You will only learn if you practice what you hear and learn at this workshop. If you apply these, which means that you work on a real research project. Work on a real research project, you design one, you conceptualize one, you write the proposal, you at least try to get funding for that proposal. Only then you will be able to really make any use of what you hear in this workshop. I don't know if it is two days, 11 and 12. So these 2 days will only be well spent if you are able to practice. Without practice, you will think, oh yeah, I heard something nice. But it would not mean much in terms of building your capacity. So I wish you the very best and would encourage you to learn with your fullest attention, but also to practice. Thank you. Have a good day.
Thank you so much, sir, for your inspiring words. Thank you, sir, for joining us. Now, we would like to move to our next agenda, and I request the organizer to kindly arrange the chairs on the dais. So now moving on to the next item of our agenda. I would like to invite our dignitaries on the dais, and I would request our organizing team, the reception and felicitation team, to kindly felicitate our dignitaries as they come on the stage. So firstly, I would like to invite Dr. Suman Kanwar, Director of ICMR RMRC, to kindly come up on the stage, sir. And I would like to request Khan sir to kindly come forward to felicitate sir. Thank you so much, sir. Next, I would like to invite Dr. Subarna Roy, sir, Director, ICMR and ITM Belgavi. I would like to request Dr. P.K. Bora, sir, to kindly felicitate Director, sir. Thank you, sir. Next, I would like to invite Dr. Prem Moni, sir, Vice Dean and Professor, Division of Epidemiology, Biostatistics and Population Health, St. John Medical College and Research Institute, Bangalore. I would like to request Director, sir, Dr. Suman Kanungo, sir, to kindly felicitate our eminent resource person. Thank you, sir. Next, I would like to invite Dr. Sanjay Javekar, sir. He is the consultant research in KEM Hospital and Research Center in Pune, and professor in health science, KEM Hospital Research Center, Pune, and professor in anthropology, Savitribai Phule, Pune University, Pune. I would like to request our director, sir, Dr. Suman, sir, again, to kindly felicitate Sanjay Javekar, sir. Thank you, sir. Next, I would like to invite Dr. Melin Mehta, sir, Director, Negrim Silong. I would like to request Dr. Subarna Roy, sir, to kindly felicitate Dr. Melin Mehta, sir. Thank you, sir. Next, I would like to invite Dr. Professor Pratap Tharian, retired professor of psychiatry and adjunct professor clinical epidemiology unit at the Christian Medical College and Hospital, Vellore. I would like to invite Dr. Subarna Roy, sir, to kindly felicitate Dr. Tharian, sir. Now I would like to invite Dr. Vishwajit Kumar, sir, founder and chief scientist of the Community Empowerment Lab. I would like to invite Roy, sir, to kindly felicitate, sir. Thank you, sir. Now I would like to, we would like to felicitate the organizing secretaries. So I would request P.K. Bora, sir, to let. Okay. I would like to invite Dr. R. Lakshmi Narayan, sir, DDG admin of from ICMR headquarters, to kindly come on the stage. I would like to request Dr. Suman, sir, to kindly felicitate Lakshmi Narayan, sir. Thank you so much, sir. Now, I would like to invite Dr. Subarna Roy, sir, to address the gathering. So Roy sir is the director of ICMR NITM Belgavi, and he was our director in charge since till recently. So I would like to invite Dr. Subarna Roy sir for his speech. Sir, kindly take the stage.
Namaskar. A very good morning to all of you. Respected Secretary DHR, DG ICMR, our mentor and guide, Dr. Rajiv Bahl. I don't know whether he is still online or not, but he has been the strength behind us in not only organizing this workshop, but in all our functions that we are doing across the institutes of ICMR. Dr. Sangamitra Pati, Additional Director General, ICMR, other dignitaries in ICMR and outside who have joined us online. The dignitaries on the dais, Dr. R. Lakshminarayanan, the ADG of ICMR, who has been the main pillar behind this particular event. And it was on his wish and interest that the first file was moved. And he is the person who actually has been responsible for getting all of us together on this day at this venue. Professor Pratap Tarian, Dr. Sanjay Juvekar, Dr. Vishwajit Kumar, Professor Prem Moni, Dr. Nalin Mehta, the new director of RMRC Northeast Dibrugarh, and a very good friend of mine, Dr. Suman Kanungo, dignitaries of the dais, esteemed faculty, my colleagues from RMRC Dibrugarh, and most importantly, the participants of this program. So it is a privilege and honor for us to host this program here, the Research Methodology Workshop, specifically for the Northeast. As we all know, this region has all kinds of diseases that actually affect most of us, and they're present in various forms across different states here. And in the 4 months that I was in charge of RMRC Dibrugarh as an interim additional charge, what I have seen is the tremendous patronage, stakeholding, and involvement of the state, of the medical colleges, of the research institutions, of the universities, along with the immense number of studies that we are doing across length and breadth of Northeast India. We have our 6 MRHRUs located in the various states, and we are going to add one more very shortly. And it is through these units as well that our research ambit has increased tremendously over the last 2 years. And the number of projects and the number of research questions that come to us are now enormous. And what I have learned in these 4 months is that there is a tremendous opportunity to actually address these issues. And therefore, we need to carry out good research, quality research, which our DG sir has said they should be world class, and to find answers to some of the questions that not only plague the northeast part of India, but also at the national and the global level as well. So this workshop is actually tailor-made to meet that target. It is to develop capacity, and the importance of doing good research cannot be ignored. A simple example I tell you, I had the National Institute of Traditional Medicine in Belgaum in Karnataka, which is the ICMR Institute for taking the leads from traditional medicines forward into modern medicine and practices. Now, we are also a kind of learning, in the process of learning, and every day we get to know many things which are new and very challenging often. One of the things that we came to know is that when we started with some of the activities of certain plants, some extracts, we have made publications, but then when we find that it actually helps, it can be actually taken forward into a development of some remedies, some formulations, some medications, then when we look at the regulatory pathways or the way we want to take them forward, we find that the procedure or the methods that we followed were not appropriate. So we have to go back again and do all the things all over again. So that results in loss of time, resources, and of course efforts. So what happens is that we just do whatever we get, and then we get good results, we publish. But that will not actually lead to the translation of the good work that we do. So therefore, it is necessary to think ahead. For example, I said about the traditional medicines. So if something, say perhaps you get some molecules, you get some active substance which you can take as a lead, that becomes a modern drug discovery pathway, the FDA pathway. If something which is used in yeah, so as I was telling, so if you get molecules, it goes through the classical drug discovery pathway. If you are validating something which is already in practice, you go by the Ayush pathway. If you are extracting something and trying to make a formulation out of it, then it will go through what is called the phytopharmaceutical pathway. So there are different pathways of taking them forward. So unless we know all these things, it becomes very difficult to kind of take them to their logical end. So therefore, understanding research and the way we do things is very important, both at our own level as scientists, as professors, as teachers, to take it forward, as well as from the research
Recording
perspective,
in progress.
from the perspective of development of products, development of technology, and empowering people. So this particular workshop will help you in understanding the needs, developing tools and methods in which you can do research which will actually be acceptable to people across the world, and at the same time develop your capabilities of thinking and also understanding some of the nuances that you have to go through during the process of your publications, your designing of research projects, your preparation of manuscripts, etc., etc. So I thank the PM ABIM scheme, which actually is enabling this kind of capacity development across the nation. And Dr. Lakshminarayana is there. He will be speaking on how he has been actually doing it across the length and breadth of the country. And this has been, sir, a very, very important activity that actually helped a lot of people. And we had been kind of having a follow-up of these activities with the participants who had been participating in this kind of programs, to actually design research projects to take their leads forward for translation. I would also like to inform you that the entire organization has been done in kind of way in which our team was here. I was in Belgaum. Sometimes I was coming twice in a month. I used to come here. Uh, People were scattered. So despite all this, our team at RMRC has tried to organize this event to the best of their abilities. And I take all the blame for all these power connections and difficulties in organizing. This is not in our hands because it is not in RMRC that we are conducting. We are doing it elsewhere. So definitely some difficulties are there in organizing that. We could have arranged at our institute as well, but we will not be able to accommodate all of you in our settings, and we don't have that many number of rooms to accommodate you. Having said that, we have also made it a point that all of you are provided with proper rooms, with the food.
Recording in progress.
So once we were discussing on telephone, Dr. Lakshminarayan told me that I have seen about this particular venue in some NIV program in virology he had come. So he said, I want it to be organized in that place. So I told our team, you go and just find out what it happens and all. There are a lot of other challenges as well. But still, I compliment our team for Dr. Bora and Dr. Siraj and his group to kind of finalize this. And we have not kind of differentiated between a junior researcher or a senior person. We have tried to give accommodation and all the logistic facilities to you. There will be difficulties, but still we tried to manage. One thing you may be noticing is that I think all the participants, the funds have been given for your travel, for your accommodation, for the food. It is not that the PM of him or ICMR or the government has a lot of money. It is because it is an investment on you. So the government feels, ICMR feels, DHR feels, and all the people who are here, they feel that this investment, giving you good food, giving you good knowledge, giving you good quality of interactions, giving you these collaborations, will take our research efforts further, magnify them manifold, and we will be able to give good research outputs as outcomes to our great nation. Thank you, and Jai Hind.
Thank you so much, sir, for your inspiring few words. Sir has been associated with us since February, and this workshop has largely been planned and being conducted under his supervision. And sir has contributed a lot for this workshop and also for the institute in general. So thank you once again, sir. Now moving on to the next item of our agenda. Now we will have the lighting of lamp from our dignitaries. So I would like to invite all the dignitaries on the dais to kindly come forward and light the lamp. I would like to request senior scientists and organizing secretaries also to kindly accompany the dignitaries while lighting the lamp.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता शेष जाड्या पहा शुक्लां ब्रह्म विचारसार परमां आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
I thank all our dignitaries and senior scientists for lighting us the lamp. And now, moving on to the next item, I would like Now moving on to the next item of our agenda. Now I would like to invite Dr. R. Laxminarayan sir, DDZ admin from ICMR headquarters New Delhi to give his address. Sir, please take your time.
Good morning, everyone. It's already late. I'll not take much time. So, from ICMR headquarters, best wishes for this workshop, and congratulations and best wishes from my side to Dr. Kanungo, who has taken over charge as director yesterday, and also from the ICMR headquarters. Also, we are thankful to Dr. Rai, Dr. Bora, and Dr. Khan and team of RMRC for arranging this program. Actually, I was here a few months back for some other virology conference. So somehow I don't know, from my start of life, I am associated with this Northeast. I was posted here when I was in armed force. So Northeast is so attraction to me to come here and discuss with you people about the research going on here. And then one day he came to me and I said, if it is, because I have given one fund to him for traditional medicine. I said, you have taken over charge in Northeast. If you do something here, okay, up to 50 lakhs I am ready. So immediately he sent me this proposal, and thanks to DG ICMR also for accepting this proposal and giving the fund. And this is actually what he has said. Simply I say, it's a PM Abhim program, Prime Minister Ayushman Bharat scheme. So here we have 1670 crores. In 1670 crores, we have several activities. Main activities are about the construction of biosafety laboratories, 9 BSL-3 and 2 BSL-4 laboratories across the country, and 1 BSL-4 is coming up in Dibrugarh. So you people are so lucky that this BSL-4 is coming at RMRC Dibrugarh for Northeast, and that is also part of PM Abhim. And this capacity building program, we are doing it across, and till now we have conducted several capacity building programs, including in the capacity building programs for our scientists. Our scientists are nowadays going to IIMs for management trainings. Our technical staff, they are doing it in IITs. So this component of this PM Abhim is really helpful. And this month I am retiring, so I have no time, because I just yesterday night I ended up one meeting at Delhi, and these three people there, they were behind me. Please come, please. Just I have landed at the airport and I have come. So tomorrow I am again leaving to Delhi. And my best wishes to all the participants as well as ICMR. This month end I am going to retire. So best wishes, all the best. Thank you.
Thank you so much, sir, for your speech and for all the administrative approval that you have enabled us to conduct this beautiful program. Thank you so much, sir. And we wish you happy retirement life in advance and best wishes for your next inning of your life, sir. Thank you so much, sir. And now we have with us Dr. R.M. Pandey, sir, one of our eminent resource persons. I would like to request sir to kindly come forward. We would like to felicitate with a gamsa. So I would invite Dr. Subarna Roy, sir, to kindly felicitate R.M. Pandey, sir. Thank you so much, sir. Sir will be taking session sometime in the afternoon. So to continue the felicitation, I would like to, we'd like to felicitate the organizing team as well. So I would like to invite Dr. P.K. Boras, sir, to kindly come forward. Sir, please. Yes. And I would like to request Khan, sir, to kindly come forward, and Boras, sir, will felicitate Khan, sir, first. Thank you, sir. And I request Boras, sir, to kindly remain, as we want to felicitate him as well. So I would like to request Roy, sir, again to kindly felicitate sir. I would like to request Roy, sir, to kindly remain, and I would like to invite Dr. Saurabh Patgiri. He's also the organizing secretary, so we'd like to felicitate him with a gamma, sir. Thank you so much, sir. So with this, we conclude our inaugural session. So now we will have a group photo just outside of this hall. So we will all move for the group photo, and then after that we will break for tea. And right after tea, we will come back for the scientific session. So thank you all. Have a nice time.
hello, 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 check, hello, hello, hello.
मैक्सिमम तो क्या बोलेगा ये मेरा वो थोड़ा ज्यादा रहेगा
वो कम समझता है बातों को, पता नहीं। और कल मुझे
आज किसी मैडम को बोल रहा है
क्या
Attention everyone, we will begin the next session in 5 minutes. So I would request everyone to kindly settle down. We will begin the session in next 5 minutes. Thank you.
Hello, 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 hello.
Hello, everyone. Hope we all have our tea and snacks. So now we would begin the next session now. So we would like to begin the scientific session. And just before that, we would have a round of introduction from the delegates among the participants. So firstly, I would like to go by state-wise so that in future we will get to know, like for any future collaboration and all, we will be able to identify more. So yeah, so I would like to request all the delegates coming from Manipur to kindly raise their hand. Manipur. Okay, Manipur, this table and there. Can we please pass on the mic to them? Okay. Please kindly introduce your name, your the qualification, and maybe just one line of expectations from this workshop. Just one line, yes. Thank you. Go ahead, sir.
Very good morning, everyone. I am Professor K. Birla Singh and from Department of Life Science, Manipur University. And thank you so much, the organizer, for giving us the wonderful hospitality, wonderful arrangement. And we are expecting a lot from this workshop because you know that Manipur is now in a crisis, and we are living in a very unpredictable and unstable situation. But even though we are, hoping that, after attending this workshop, we will definitely submit another major project to the ICMR, and we will surely get funded from on the novel endeavor of our proposal. Thank you so much, everyone.
Good morning, everyone. Myself is Yaifaba Maite, assistant professor and PhD from Delhi University, and working as assistant professor in the Department of Anthropology, Manipur University. I think it's the first time that such an workshop has been organized in the Northeast India, and being a platform. So I congratulate and thanks to ICMR for giving such a platform to interact all the medical or health researchers from different parts of the Northeast India to come together. And I expect in the coming near future, there will be a bigger and collaborative project and work having a major health issues in the Northeast India. Thank you.
Hello, good morning everyone. I am Professor Ratan Konjingpom. I am a professor of pathology, and I'm also LRC member of the MRU RIMS Imphal. And regarding about this workshop, I think it will very beneficial to us, as we also conducting capacity building in our RIMS also, in MRU also. So I think it will, from here we'll learn and we'll try to implement in our institute also. Thank you very much.
Hi, good morning everyone, and greetings from MRU RIMS. I'm Dr. Ziten, Professor of Medicine. I'm working as the Nodal Officer of MRU RIMS. I think the title itself shows it's kind of capacity building in research methodology. I think the importance and significance at this point of time cannot be overstated. Best wishes to everyone. Let us build a platform, and of course, I'm looking forward to the outcome very soon and in a big way. Congratulations, everyone. Thank you.
Yes, delegates from CMC, can you pass the mic to this side? Mic.
Hello everyone, my name is Dr. Gai Hamlung Pamay. I'm from Chuchampu Medical College, assistant professor in the Department of Community Medicine. So I'm looking forward to this very important workshop to learn and to implement all of these things that we have learned today and to refresh our memories. So I give my mic to the next.
Good morning, everyone. I'm Dr. Soyongam Rogui, Assistant Professor in Department of Forensic Medicine from Chirapatrampu Medical College. In this workshop, I intend to learn everything about research and implement it, especially in our institute. Thank you for giving us this platform.
Thank you all so much. Manipur dagi lengbirakpa delegate singbu ehakna harau tamna okchari amadi thagatpa phongdokchari nungaizari Manipur. Now moving on to Mizoram. Can I see the hands of delegates from Mizoram? Yes, kindly pass the mic to them. Yes, kindly introduce your name, your qualification, and what you expect from this workshop in just one line, please. Go ahead, sir.
Hello, everyone. I am Dr. H. Lar Huitluanga from Department of Biotechnology, Mizoram University, and I'm very happy to be a part of in this capacity building. Thank you very much.
Greetings, everyone. I am Dr. Rebecca Ngaizwari, Assistant Professor, Department of Microbiology, Zora Medical College.
Good afternoon, everyone. Myself, Professor Swagnik Roy, Head of the Department, Microbiology, Zora Medical College.
Yeah, good morning. I'm Senthil Kumar from Biotechnology Department, Zora University. So we work on the genomics and epidemiology of various cancers as well as other diseases. So this workshop is going to be a platform for closer interaction with the clinical side as well as the researcher side. Yeah, thank you.
Thank you all so much. Mizoram Iowa local zong te in zavain kanlo muha kachiu. He workshop block pui turin do sagna sang berkaron han bokani kanlo me. Okay, now coming to Meghalaya. So may I see the hands of delegates from Meghalaya, please? Yes, kindly pass the mic to them. Sir, please go ahead and introduce yourself.
Very good morning. I am Professor Dinesh Bhatia. I am from the Department of Biomedical Engineering at NEHU Shillong. I am a bachelor's and master's in biomedical engineering from Mumbai University, and I have done my PhD from MNIT Allahabad. I am also the recipient of Boykost Fellowship from DST and ICMR Young Scientist from ICMR, and I worked in Florida International University and the University of Glasgow. I work on cognitive neuroscience, and I work on people with disability. Thank you.
Good morning, everyone. I'm Dr. Manojit Gogoi from Department of Biomedical Engineering, NEHU Shillong. I'm an assistant professor. I'm working on the field of medical device development. So I want to learn something like clinical trials of medical devices. That's my expectation from this workshop.
A very good morning to all of you. This is Dr. Nitin from Department of Biomedical Engineering, NEHU Shillong. I used to work in 3D printing of various applications of 3D printing in medical devices, development, rehabilitation, prosthetics, orthotics, organ on chip, tissue engineering. Major takeaway from this workshop, the process, the guidelines, how to frame the projects, and what are the medical ethics involved, and the relevant research questions, how to develop research questions for this. Thank you very much.
Good morning, ladies and gentlemen. I am Dr. Ruben Lamiaki Kinta. I am Associate Professor in the Department of Cardiothoracic and Vascular Surgery. I am a cardiac surgeon, and I have come here to understand the barriers from bench to bed, because in being a maximally invasive surgeon, there are a lot of barriers in my research. So I expect to learn ways to overcome these barriers. Thank you.
Good morning, everyone. I'm Dr. Badamudlang Dimpep. I'm from Shillong, and I'm an assistant professor in burns and plastic surgery from NAGRIMS. So this workshop will really boost our knowledge and also our approach, especially on the clinical aspect, because what I've observed, many of the delegates here, maybe not from many of the clinical background, but from the
Thank you all so much. Okay, let me try this. Nga pidyang snack ba ye barok in nong mikad ma na Meghalaya kublai sibun. Bear with me. So now moving on to Tripura. May I see the hands of delegates from Tripura? Yes. Please pass on the mic.
Good morning to all. I'm Dr. Aizara Marak. I'm working as assistant professor in the Agartala Government Medical College. So first of all, I just want to thank all the organizers for inviting us for this workshop. Actually, in our department especially, whenever we want to have research work in anything, we tend to get the opinion, help from the community department, community medicine department. But I just hope this workshop will help us to gain more knowledge on research methodology and all the related things. Thank you.
Very good morning to everybody. Myself, Dr. Pradipta Narayan Chakraborty. I'm working as an assistant professor in the Department of Forensic Medicine and Toxicology, AGMC and GP Hospital, Agartala. First of all, I would like to thank the organizers for giving us the chance to attend this grand event. And I hope that I will learn a lot from this workshop and can help my departmental works and my institute. Thank you.
Good morning, everyone. Myself, I am Dr. Bhupati Ranjan Riyang, working as a senior resident at Department of Transfusion Medicine. And I would like to thank the ICMR for giving us this opportunity to learn about this research methodology. In our department, this transfusion medicine is in a nascent stage. Till now, we couldn't do so much. After attending this workshop, we hope to do more research and produce more papers, which are the quality will be which we will meet international standard. So I once again thank the organizers for giving us this opportunity to learn about research methodology. Thank you.
Good morning, everyone. Myself, Dr. Sudip Bhattacharjee, Department of Library and Information Science, Maharaja Bir Bikram University, Agartala, Tripura. First of all, I would like to thank ICMR organizing committee for giving me this opportunity. And regarding this practice, so I am, though I am from the Department of Library and Information Science, but as a multidisciplinary practice, we are running some healing practice what are performed by indigenous people. So, from this workshop, I would like to think that I will come to know lots of the things so that I can improve my research activity. Thank you.
Hello everybody, it's Dr. Devdatta Adak from Maharaja Bir Bikram University, and I'm happy to be here because I work in epidemiology, and so that as one of the topics is prioritize the regional and national diseases, so I believe it will be much more helpful for me to understand the research trends in epidemiology in this northeastern region. Thank you.
Thank you so much. আমি ত্রিপুরা থেকে অগত প্রতিনিধিদের আন্তরিকভাবে স্বাগত জানাই ধন্যবাদ
Hello.
Sorry I could not get translated into Cockbrook, so okay, we get one more. Yes, sir, go ahead.
Hello, good morning to everyone. I am Professor Samir Kumar Sil from Department of Human Physiology, Tripura University. I'm the head of the department right now. So I've been attached to the research of Northeast India for quite some time now, maybe 20-25 years. I've been working especially on hepatitis B virus and HPV and cervical cancer. And I think this platform will give us a fruitful collaboration with so many luminaries and good scientists over here from across the states, especially Northeast India. And this will give us opportunities to make fruitful collaboration, I hope. to give more fruitful, outcomes in terms of what is it for the betterment of the health of this region. Thank you very much.
Thank you so much, sir. Just one request. One request from the participant, just don't thank the ICMR yet. Okay, so tomorrow at the vote of thanks session, we'll have that thank you note. So just one line of expectation, please. So now we'll move on to Nagaland. Nagaland delegates, can I see your hands? Yes. Yes, madam.
A very good morning to everyone. I'm Dr. Tila T. Jamir, Assistant Professor of Microbiology in the Nagaland Institute of Medical Science and Research, Kohima, and also a member of the LRAC of MRHU Nagaland. From this workshop, I hope that our scope of understanding and producing quality research will be enhanced for our state, as well as we can produce good results with implementational research, which I really hope that we can really learn from this workshop. Thank you so much.
Good morning, everyone. My name is Dr. Sanap. I'm an assistant professor in the Department of Pathology in NIMSER, Kohima.
Good morning, everyone. I'm Dr. Moanaro Longchar. I'm assistant professor in the Department of Pathology in NIMSAR, Kohima. Well, our college is very new, just 3 and giving us an opportunity to be here. We believe that this particular workshop, that is capacity building and research methodology, would help our respective departments, our institute in particular, as well as our state in general, with all the knowledge that we go back. Thank you.
Good morning, everyone. Myself, Dr. Farooq Ahmed, working as an assistant professor from Nagaland, Kohima. So, hope whatever we have learned today or tomorrow, we can implement in future and very well. Thank you.
Yeah, good morning, everyone. I'm Dr. Thomas Kapan, Deputy Director of Health and Family Welfare. Perhaps I'm the only one who has come from a non-academic background here, but coming purely from a policy and program implementation point of view, I think this capacity building is very important in the government, in the governance. And then with the growing need for good data for policy implementations programs, I think this is going to help us more. So looking forward to the next 2 days.
Thank you all so much. Nagaland laga delegates khan sop kemon khosi pera salam tiase. Now coming to Arunachal Pradesh. May I see your hand, Arunachal delegates? Yes. Kindly pass the mic to them, please.
Good morning, everybody. I am Dr. Yompe Kamke, Assistant Professor, Department of Microbiology, TRIMS, Arunachal Pradesh. So after 2 days this workshop, I expect that we will be able to take up research which is beneficial for the public, especially particularly for the people of Arunachal Pradesh and whole of the country as in general. And thank you for the nice accommodation. Thank you.
I am Dr. Pallavi Boro. I am Associate Professor in the Department of Community Medicine, TRIMS, Arunachal Pradesh. So at the end of the workshop, I wish we know more about the different institutions, and we can have some kind of interdepartmental and interstate collaborative research in future. Thank you, sir.
Good morning, everybody. I'm Dr. Sorang Tasok, Assistant Professor, Department of General Medicine, Lagan. I believe these 2 days will enlighten us in the research building. Thank you.
Hello, everyone. I'm Dr. Navam Peter.
I'm a medical graduate, but I've done my master's in medical science and technology from IIT Kharagpur. I'm currently working as a health research scientist in the Directorate of Medical Education, and I've also taken up the charge of nodal officer for multidisciplinary research unit TRIMS. From this workshop, I see the content of the workshop is very made in such a way that it will enrich our understanding and broaden our scope of the understanding and doing research in a better way. Thank you.
Thank you all so much. मैं अरुणाचल प्रदेश से आए सभी प्रतिनिधियों का हार्दिक आप सभी स्वागत करता हूं. Now, coming to Assam, Sikkim will be last. So, delegates from Assam, excluding RMRC team. So, may I please see your hands, Assam team? Yes.
Good morning, everyone. I'm Dr. Anuradha Barua, Professor Head Anatomy, Assam Medical College, Dibrugarh. I have come here to refine my knowledge. Actually, whatever we have done till now, maybe it is without grammatical teaching. I want to streamline my knowledge regarding the research and other things. Thank you.
Good morning, everyone. Myself, Dr. Abanti Bora Burua. I'm the professor and head Department of Physiology, Assam Medical College, Dibrugarh. And with the knowledge that I gained in this workshop, I intend to take to my own institute and promote research works in our institute. Thank you.
Good morning, everyone. I'm Dr. Sharnali Chaudhary, Assistant Professor, Department of Biochemistry, Assam Medical College. So after this workshop, I think I'll be able to formulate a better study design and also guide my juniors regarding the research methodology. Thank you.
Can we please pass the mic to the first table as well for sir and madam?
Hello. Namaskar. I am Dr. Navajit Kumar Das. I am from Department of Anthropology, Guwahati University. I'm very much optimistic regarding this program, and I think this program will enrich our knowledge regarding the subject of research methodology in the field of. And I believe that after this program, we all are able to develop some quality research, probably with ICMR, which will directly benefit our community in near future. Thank you.
Hello, good morning to everyone. Myself Ratul Mahanta. I am from Economics Department. I'm the head of Economics Department. I had my PhD from IIT Guwahati and the postdoc from Sam Houston University, Texas. I basically work in health economics. So I had one or two projects in arsenic. So while doing the project, I could see there are many gaps, although we did a lot of research on the arsenic, but I could see while going through the village that there are a lot of, the people are not that much aware of some of the terminology. In that case, I also had some one or two capacity building to know these are the terminology. And because I could see that there are a lot of fantastic work that we do in our basically the lab or in our medicine sciences, but these are not replicated to the society. So I do always feel that besides having the statistical significance of our work, we should have also social significance. So therefore, I do believe that our work sometimes always have to be some related to their society. Although I have seen that there are a lot of, I would say, the inequality and in the inter-district and within the district also. So I would suggest, or I would expect from this workshop that besides publishing, because knowing how to publish good works, or to work, I should also have some idea about how to develop, to make some capacity building for the society. Thank you, all of you.
Good morning, everyone. And I think we will all agree we are here today because of our common interest of health research. And health, as we all know, is the outcome of both
cultural practices and behavioral factors, we all know that. And so coming from the Department of Anthropology, though I am in health research, I believe and very strongly understand that our health outcomes and consequences are, behavioral aspects have a lot to do with it. So in the process, I think both medics and non-medics can collaborate to bring out more meaningful research, health research specifically, for applied aspects like the development of policies or maybe intervention mechanisms. I happen to be a professor at the Department of Anthropology in Guwahati University, and my PhD guidance and as well as my projects, in all my projects, health research, health has been the focal point. And my primary area of research is anthropological gerontology. But I have worked in other health issues also among adult populations. And to take back from this workshop, I hope we will be able to refresh our research methodological aspects in a better way and maybe incorporate some of the aspects in our future research and also find mechanisms for collaborations with ICMR or other medical professionals. Thank you.
Hello. Good morning, everyone. My name is Dr. Aditya Kumar, currently working as an assistant professor at Tejpur University. I did my PhD from Indian Institute of Science, Bangalore, and I work in the area of computational biology and artificial intelligence. And at this moment, I would like to thank ICMR, who conducted last year in February one grant writing workshop. This workshop was so good for me. It was mentored by Nalin Mehta sir, R.M. Pandey sir, and Vishwadit sir. And it was so good for me. I secured not only from ICMR 2 grants, I secured from DBTA as well. So currently I am holding around 3.5 crore grants. Thank you so much for organizing this meeting also. And now I aim more. And please include me, and if you are interested in working in artificial intelligence and computational biology and in all the areas of genomics. Thank you.
Good morning, everyone. I'm Dr. Valentina Teronpi. I'm working as an associate professor in Department of Zoology, Rabindranath Tagore University, Hojai. So I'm honored to be part of this workshop, and from this workshop, I hope to strengthen my understanding of research methodology, especially in the field of health research. So I thank ICMR for giving us this platform to interact and collaborate with other researchers. Thank you so much.
Good morning, everyone. I'm Dr. Resha Goswami, Assistant Professor of Physiology from GMCH, Guwahati, and immensely happy to be participating in this workshop in the midst of eminent speakers and researchers and delegates from varied fields. And I hope I'll be able to give back to my college and my department after this. Thank you.
Good morning, everyone. I am Dr. Kumail Goswami, Assistant Professor, Department of Community Medicine, Guwahati Medical College. Our institution, GMC, is already associated with lots of research activities, means funded, sponsored by ICMR. I am also associated with one clinical trial, but research is a means subject topic. I have already attended so many workshops on research methodology, but still we have a lot to learn from this. And being a part of this workshop, definitely I will learn a lot, expecting it. Thank you.
Good morning, everyone. I'm Dr. Manashi Burman, Assistant Professor, Department of General Medicine, Guwahati Medical College. Thank you.
Good morning, everyone. I'm Dr. Panchami Sarma. I'm a registrar at ONG Department, Guwahati Medical College. and I'm hoping to take back whatever I learn and pass it on to my juniors as well for their guidance. Thank you.
Good morning. Myself, Dr. Setanjit Burwa, Assistant Professor at Tinsukia Medical College, Department of Community Medicine. I am here to know about the scope of health research in North States. Thank you.
Very good morning to all of you. I am Dr. Parthojyoti Hazarika, Department of Statistics, and at present I am an associate professor of that particular department. And I just come here to learn something new here. Thank you.
Good morning to all. Myself, Rubodas, Assistant Professor, Department of Statistics, Dibrugarh University. I hope I can learn something from this workshop so that I can enhance my research work in near future. Thank you. Thank you very much.
Any other delegate?
Hello. Hello, my name is Dr. Akono Sakre. I am working in the Department of Anthropology, Dibrugarh University. And my specialization, I did my PhD from Hyderabad Central University. And my specialization was on anthropology of food. Today, as I attend this workshop, I hope to enhance my research capacity. As the title says, capacity building. I hope to enrich my capacity on, especially on in the field of health research through this workshop. Thank you.
Anybody else from Assam? Okay. Thank you all so much. Moi akhomor holoku honamiyo bhakti totha pratinidik swagatam janaisu. Thank you all. Now, last but not the least, delegates from Sikkim. Yes. Please go ahead. Yes.
Hello, good morning everyone. I'm Dr. Rekha Sharma, Assistant Professor in the Department of Microbiology. I want to enhance my knowledge and learn something new in this workshop and to take it back and do a quality research in the institute and the state. Thank you.
Good morning all. I am Professor Champa Sharma, Principal, Sikkim Manipal College of Nursing. As Manipal is already taken so many research, so from this workshop I may refine my knowledge which already I have. Thank you.
Good morning everyone. I am Professor and Principal at Sikkim Manipal College of Physiotherapy. My purpose to attend this workshop is to enhance, improve quality of research and wish to apply collaborative research with other institutions. Thank you.
Good morning to all. I am Dr. Dichenla Chiring Bhutia. I'm Professor and Head of Department in the Department of Community Medicine at Sikkim Manipal Institute of Medical Sciences. Looking at the various representation from different states of Northeast, I take opportunity from this workshop to network and collaborate with everyone. And secondly, also to refine my knowledge and update my knowledge on research methodology. Thank you.
Thank you all so much. Sorry, I could not get my translation done in either Lepcha, Bhutia or Nepali at this time. So I will come again in the next round. So for one of time, we would skip the introduction of RMRC team for a while. We will introduce the RMRC team in some other sessions. So now, as we have all known, we have gathered from all over the 8 sister states of Northeast, from Mismi Hills in Arunachal Pradesh to Lusai Hills of Mizoram, the Khasi Jante Garo Hills from Meghalaya, from Manipur, the hills and valleys, and to the North Kachar and to the fertile Kachar and Brahmaputra plains. We gather here today. So I welcome you all once again. And in our midst, we have another eminent resource person with us here. So we would like to felicitate Samiran Panda sir. Sir has been the Dr. A.S. Pantel Distinguished Scientist Chair and also the Editor-in-Chief of the Indian Journal of Medical Research, as well as the former sir to kindly forward. It's our organizing team to kindly arrange for the felicitation. I would like to request Roy sir to kindly felicitate sir.
Hello.
Thank you so much, sir. Yes. Okay, now as part of the continuation of our inaugural address, I would like to invite Dr. Dharmesh Lal, Scientist E from ICMR headquarters. He has been one of the key persons for organizing this event. So I would like to request Dharmesh Lal, sir, to kindly address us the gathering through video conferencing. Dharmesh, sir, kindly take your time.
Can you hear me?
Yes, sir. Please go ahead, sir.
Thank you. So, good morning all. It has been a privilege to be part of organizing this event of such magnitude and importance. First of all, my apologies for not being there in person. And from very beginning, I was very keen to be part of this and including even taking at least one session on research methodology. But because of my other engagement, right now I am in for some other engagement in Bangalore. And that is the reason I was not able to attend in person. But seeing the agenda and the speakers, the eminent speakers, my seniors, most of them are my seniors. And I am sure that you are going to have many takeaways after you are able to complete this workshop. Northeast is having a special importance in our Indian health system. And there are a lot of research areas where we can come out and design certain studies, whether it is clinical trials, implementation research, basic research, operational research, so that we can contribute to the diseases which are important for having regional importance and largely the national importance. And because of its geography, culture, beliefs, and thereby the consequent health delivery system, Northeast as a whole also requires certain specific research studies to be done so that those specific issues could be addressed. And the another important aspect of this workshop, which I would like to share with you, and why I was keen also, that after we attend this workshop and we are able, after completion of this workshop, all of us need to think about developing and coming out certain studies about how the country is going to respond if at all there is to be another pandemic or epidemics in some certain geographies of Northeast, so that country gets better prepared for pandemic response and its qualitative aspect as well of kind of response we are going to have in those kind of situations, as we had all of us had seen in during the COVID-19 pandemic. And right now also there has been a kind of a spread is being reported from many parts of the country. So that is also one important aspect we need to focus upon. And I look forward that all of us, when you go back and have this also into consideration for formulating certain studies, which leads to the better pandemic preparedness. And the third component which I would like to request to all of you is to come out and think about, contemplate about certain research priorities which we need to have. Because now with day by day increasing challenge of climate changes and its consequent on health aspects, as we all of us are experiencing. So we need to work on that as well, and then for that the One Health is an important aspect needed to be worked out. So that I would request to all of us to focus and think about those aspects also. And for that, what I can suggest to all of you is that at district level we can plan out certain studies at the district level for One Health issues, and later on those can be submerged on enlarged at the state national level, so that the country also have a certain plans for addressing the issues emanating from One Health. And I'm very happy seeing the agenda of the workshop which has been formulated, and I am sure the kind of speaker, the content, the way it has been organized, it has to be going to be a great success. So all the best to all of you in your future research journey. Thanks.
Thank you so much, sir, for your address to the gathering. Now, we would like to start the first scientific session. This session on the importance of reliable evidence to inform health decisions. This session will be taken up by Professor Dr. Pratap Tharian. Sir is a retired professor in psychiatry and adjunct professor in clinical epidemiology unit of the Christian Medical College and Hospital, Vellore, Tamil Nadu. So I would like to request Tharian sir to kindly take your time. Sir, this is the pointer. Yeah.
Morning. I know it's kind of late in the day to start a scientific session, but I've come from a long way and I have to share a lot of stuff with you. So please bear with me. I'm Pratap. I'm a clinician and I got dragged into this world of research by accident. But what I'd like to share with all of you is stuff that you can keep in mind when you plan new research. So what have we learned from research done in the past? What I hope is you'll be able to appreciate what constitutes reliable evidence that can improve health outcomes and understand how poor study methods and poor research integrity can undermine the reliability of the evidence and can result in harm. And I really want you to appreciate the difference between statistical significance and clinical importance, particularly minimum clinical important difference between the evaluations you're evaluating, and then appreciate the role of evidence synthesis in informing these health decisions, and understand how this evidence is contextualized and evaluated when you're trying to make policy decisions. So that when you appreciate all this, when you plan and conduct research, you need to consider why are you doing this research, who is likely to use the results, and who will benefit. That's really important to keep that in mind. I got involved in this field more than 30 years ago when this term was being coined, evidence-based medicine, when Gordon Guyatt and Dave Sackett arrived at this consensus definition that evidence-based medicine is the integration of research evidence, clinical expertise, and patient values. So the clinician is at the center of this whole process. But unless the clinician can access and interpret reliable evidence, he really cannot make decisions that will improve health outcomes. So the big issue is, can the available evidence be trusted? Unfortunately, I'm a bearer of bad news. There is a lot of evidence out there that suggests that a lot of research evidence is false and cannot be relied on. In fact, around the time the Cochrane collaboration was being founded, Doug Altman, who was a senior statistician, said, we actually need less research, better research, and research done for the right reasons. And he gave you this analogy. What would you think if you found a doctor who willfully or through ignorance did something that caused harm to a patient? You would sue him or kill him in some parts of the world. Why is it that when we find similar stuff that happens in research, where people who are researchers, either through ignorance or willfully, use the right techniques wrongly, misinterpret the results, report their results selectively, cite the results selectively, and draw unjustified conclusions? We should be equally appalled, but we are not. And this is a scandal. So why can't we always trust research? And one of the main reasons is that the agenda has been hijacked. People tell you this is how it needs to be done, and you have to follow their vested interests. And this often leads to a lot of research being published. But when people try and follow that research, it does not improve health outcomes in the real world. So some time ago, I wrote an article for the Indian Journal of Medical Ethics trying to explain this. And one of the major reasons behind this is conflicts of interest, commercial as well as academic. People forget that academicians have huge conflicts of interest, and unless they realize it and we appreciate that, we will be misled. So a lot of unnecessary, inappropriate, poorly designed and poorly reported research is there. And many studies are manipulated. The design is manipulated in the choice of the comparators and the outcomes being evaluated to give results that people want. And manipulation of statistics is very common. There is also a huge over-reliance on p-values. And we'll discuss that in a bit, because p-values have served their purpose, but there are other ways of looking at evidence. And a lot of people selectively report outcomes or even report studies which are not significant. And there is this huge problem, increasing problem of ghostwriting, where there are public relations companies which will write your research for you and give you an authorship. They are the ghosts. And there's also an increasing tendency to disease mongering, manufacture disease, so that we can sell more products and treat more patients. And there's a lot of marketing of products designed as education. All of these lead to unreliable research publications and suboptimal health outcomes. I'm very happy to hear that, and why did I write this for the Indian Journal of Medical Ethics? Because you can have an ethically designed study, but unless it has a little chance of providing reliable results, that is unethical. So science and ethics are inseparable. I was very pleased to hear your interest in anthropology and disease, because this is an article which came out yesterday in the New England, in JAMA Internal Medicine, and it talks about the impact of definitions of disease on overdiagnosis. And it starts off by saying, WHO has defined what is health, but it has not defined what is disease. And our understanding of disease comes through the years from biology, but it is influenced increasingly by social, cultural, and economic factors. What is disease and what is not disease? And definitions are important, and how we label a definition can determine how society perceives it, manages it, and supports. But just take a look at the table on the right. People who studied in my time, our definitions were at the lower end. Cholesterol, 240, fasting glucose, 126, systolic blood pressure, 140, or even more. Today, it's getting more and more and more tight. And what then happens is that you increase the number of people who are ill by that definition. Right? So the problem is continuously expanding disease criteria can reduce underdiagnosis, of course, and inappropriate, and increase appropriate care. But more often than not, they often result in overdiagnosis, resulting in overtreatment, low-value care, and ultimately threatening our ability to deal with all these people with all these diagnoses. And technology will give you better and better MRI scans, much, much higher resolution, which will pick up incidental stuff, which you will have to chase. So we have to be very cautious about the way science is progressing, and we have to decide, what do we want? This is another thing which is very prevalent, and I'm bringing this to you to let you know that people are now looking at what academicians do. We are sitting here to publish and do research and publish. But there is a lot of evidence to say that the metrics of publication and citations have become the target. And there are people who are considered to have hyper-profile authorships, which is defined as more than 40 publications by that person in 1 year, right? And there are publication and citation clusters within closed institutional networks and strategic publication in predatory journals. Many of these journals get delisted and papers often get retracted. And there are questionable authorship practices like gift authorship, guest authorship, ghost authorship, sold authorship, you name it. And people have multiple affiliations in different institutions around the world. So each time one person gets affiliated, all those institutions will claim it as their publication. So this is a business. So there is apparently a law called Goodhart's law. When the measure becomes the target, it ceases to be a good measure of the value of what is being done. So when you start your career, think about this. Okay, this is the results of their way of looking at it, and I'm focusing only on the studies from India. Now what they've got is there are certain study groups, all private, right? Look at the number of articles published in 2018, 2019 to 2023, 2024. And look at the percentage of increase in that time period from the institution themselves and for the country. And look at the way their rankings have jumped in that period of time. And the control group was, for them was, this article was Indian Institute of Science. Compare that with the metrics from the Institute of Science. There is an increase in publications, but it's not as dramatic as in the previous places. And what then happened is, look at their ranking. Their ranking actually came down. Not that they're not doing good work, but because other people's rankings push them down. So this is the business that y'all are entering into, and you need to think very carefully about where you want to be, right? And there are citation hubs, which this is a business for them. Okay. So it's not very surprising that people in Cochrane classified research that's available into these quadrants as on the top you have research which is advancing medical science. The other end you have research which is very practical. And then you have a quadrant which combines the two and says it is advancing science and has practical applications. But the vast majority of research in high impact journals is what you'd consider research waste. It doesn't help anybody except the publication metrics. Okay, so there are also a whole series of articles in the Lancet devoted to trying to find out what causes research waste. So the first thing is the questions you're asking are of low priority to people who really want to use them, right? And many of the important outcomes that are required to make clinical decisions are not asked. And most of these studies don't look to see, is there a systematic review to tell us what is already known before you start doing new research. And the other problems are that majority of the studies are not really aware of the steps required to reduce bias when you design the study. And often they don't have statistical power to detect actual differences when they are there. And when you find that you'll get a publication and everybody will take that publication as gospel truth without trying to replicate it. Keep in mind that you can get false positive results, and that will usually get published. And if people don't try and replicate it, you will run into trouble. There's a lot of problems also in the way research is regulated, but most important is we do not try and evaluate the results of research, which are actually predictive studies, to see how does it work in real life. We don't have routinely collected rigorous data on the way we implement the results of research. So I'm happy that there's going to be a talk on implementation, right? And a lot of the time, a lot of the reports are never published in full. They're presented in conferences, right? And sometimes you'll find there is biased underreporting of studies which have got statistically non-significant results. And even within the studies that report them, non-significant results are kind of given a spin. So even if you do publish them, a lot of the studies don't describe what they did in a way that you can actually replicate it. And a lot of the planned outcomes are not reported. So there is a huge problem in the published world. Adding to that is this whole issue of research misconduct, falsification, fabrication, and plagiarism, which again distorts the research based. And researchers who at one point in time were considered to be sacred in their activities are distrusted, right? No? So you may ask, okay, what is the problem with that? The scientific records, corrects itself, a term I've often heard. But if you actually look at this, you'll find there's not only fraud, but badly done research has the same impact. So there's a study, very interesting one, where a person took from 10 years of retracted publications from PubMed. You can go to PubMed special queries and found out that there were 80 retracted papers of clinical research involving humans that were cited 5,000 times, with the majority of citations believing what was reported and influencing subsequent research. And the original studies papers retracted what they recruited 28,000 subjects, and this gave rise to 851 secondary studies which recruited 400,000 subjects. So you publish something, it can cause harm, right? So this is actually considered to be a conservative estimate, right? Now the problem is sometimes you can get retracted articles, right? But then retracted articles are often reported as a small letter to the editor, which you will never find. So even today, you can get the full PDF of retracted articles without anything saying that it's retracted. But the problem is, it can also occur because you did your study poorly, either intentionally or through naivete, but the results are the same. So when you're doing research, if you're doing it for publications, you may be causing harm. What are the causes? There is a lot of pressure on young people today. You're not considered to be anything unless you publish. And the higher you get, the competition to be the best publisher and get awards and citations and grants is great. So if grant getting and publications are your reward, God help us. Okay. So this is a very interesting slide to keep in mind. It was reported in 2006 in the Lancet that misconduct, it's a continuum. It starts as your very first research project. You make a mistake, you don't get caught, and you continue to do this. And then you ultimately get caught when you're publishing in high-impact journals. Keep this in mind. The problem also is, in the real world, you need reliable evidence. And if you don't have methods of proving that evidence, you will find this kind of stuff going on that becomes politicized. And if you look at it, the number of retracted papers published during COVID is huge. A lot of those papers have been retracted. So what we need for better health outcomes are reliable evidence that is relevant, which addresses a focused clinical question on a population intervention, comparison, or outcome. We need studies addressing that question and using designs to answer that question and reports that provide reliable answers. Then we need, that evidence needs to be evaluated to see, are they all the studies addressing this problem or only a biased subset? And each of those studies, we need to be able to evaluate what is the risk of bias in this study and across all the studies to try and arrive at a conclusion. And then when you're looking at the importance, we need to know, is it just statistical significance or is it really going to have a clinical impact? And when you put all these results together, we need to know what is the overall effect. Will it help or will it harm, or you don't know? And if it will help or harm, are the results consistent? And then when you finally decide, okay, this is good evidence, the next question comes, should I use it according to the context in which I live? So that's the way we have to look at it. So let's just get back to basics. The usual way you will do it is saying, what is the evidence? Is it statistically significant and clinically important? The next thing you'll ask is, can I trust the evidence? What is the internal validity of the paper? Are the results likely to represent the true value? And this does not change wherever in the world you read this article. That's the true value of those interventions. That's what we try and do in evidence synthesis. But we also try and see, can we give some ideas to inform people who want to use the evidence about could these results apply to you? That's called external validity. And that changes where in the world you read this article. So then you look at all the trade-off between benefits, harms, costs, resources, and that makes a good health policy. So all of us as researchers will get involved in all of this as producers of this evidence. So when you're looking at what is the evidence, we want to know what is the observed difference between groups for outcomes, for efficacy, safety, quality of life, and all of that, and answer this traditional question, testing the null hypothesis. Is it just a chance error, or is there a difference, a real difference? And you look for your p-value from a statistical test. This can be highly deceptive, right? So we need to be very clear what is the p-value. It asks you, how certain are you that the observed difference in the outcomes is due to chance or not due to chance? And you get a p-value of 1, you can be 100% sure this is due to chance. And if you get a p-value of 0, you can be 100% sure this is not due to chance. So when you get a p-value of 0.5, you have no clue. It could be chance, it need not be chance. So when you get a p-value of 0.1, you are now 90% sure this is not due to chance. So when you get this traditional p-value of 0.05, all you're saying is that you are more than 95% sure that this observed difference is not due to chance. Keep this in mind. That's all a p-value is telling you. Now look at this. I'm giving you numbers in treatment and control arms and increasing sample size with each column from 5 to 100. The next two rows give you the treatment responders and the response rate in these arms. And if you look at the treatment response in the treatment and control arm, you'll know that the number of people who responded in the treatment arm is double the number of people who responded in the control arm. And that is constant, whether you increase the sample size from 5 to 100. That's the real difference. Now we are trying to find statistical significance with a p-value, and we will note that when you have only 5 in each arm, an effective intervention will be shown. You'll say, I'm only about 69, 61% sure this is not due to chance because your sample size was too small. Your typical type 2 error. But when you increase it to 100 in each arm, you get a p-value which is what? Less than 0.0001. And you will report it as highly significant, and people will interpret it as highly important, which it was not. It was important even if the p-value was less than 0.21. So what the take-home message is, so this p-value is less than 0.0001, what it means is I am more than 99.999% sure this is not a chance difference. Right? So if you look at this difference between drug A and drug B for the remission of a depressive episode at 6 weeks and compare the proportions you improved, 1% difference, but you can get a p-value less than 0.0001. This is statistical significance, but doubtful clinical importance in the real world, right? So the take-home message is any observed difference between two groups, no matter how small, can be made to be statistically significant at any level of significance by taking a sufficiently large sample size, right? P-values only tell you about statistical significance and not about clinical importance. So for that, you know what you should do, but what you also need to know is how to interpret this properly. Estimation of effects. You know about the risk ratio. It is the most intuitive way of looking at differences. How many people died in one arm among the people given? That's the risk of death in one arm compared to the risk of death in another arm. Common sense. That gives you your risk ratio. Common sense way of looking at it. And what is the way you interpret it? It is that if you have one of respects to one, you can't tell you anything about who's better. But if you have an undesirable outcome like death, relapse, not improved, anything less than 1 or like 0.42, it means your experimental intervention was better than your comparative. So which one is better? Depending on, is it less than 1 or more than 1? If you address it in a desirable way, the interpretation is reversed. But more important, it tells you how much better. So a relative risk of 0.42 means that the intervention reduces the risk of negative outcome by 58%. expressed as a percentage. 1 minus the relative risk, or 100 minus 42. That can quantify the differences, and if it's 1.42, it means it increases the risk of the outcome by 42%, right? So this is the way you can quantify the differences. You also need to have a confidence interval, because a confidence interval is a measure of uncertainty. It tells you just one study that you do is not going to answer the question for everybody. So the confidence interval gives you an estimate that if you keep doing this study many, many times, what is the range of values that you will find your risk ratio in 95% of the time, right? So it's a measure of precision. The narrower the confidence interval, the more sure you are that you know that this effect is actually going to occur. And you usually get that by a large sample size. But you can also use it to tell you whether the difference is statistically and clinically important. Because if the confidence does not include 1, right? But if it includes 1, if it says 0.5 to 1.25, that means it could be a 50% reduction or a 25% increase. You don't know, and your p-value is automatically not significant. And if the upper and lower limits are on either side of 1, you will know it will harm or it will help. And your p-value is automatically significant. But what is more important for us to know is, what is the lower limit of the confidence interval? This one. If your lower limit is 0.73, you can say at least I can expect a 27% reduction in the risk of that outcome, which is pretty good. But if your lower limit is 0.99, I don't know, only a 1% reduction. So this is a very important way to interpret these results, and you should always strive to report these results from your own research findings. I'm quite happy to give you these slides so you don't have to photograph them. So keep in mind the odds ratio. The odds ratio is a different way, but you need to know how to use them properly. Here, it's the odds of living or dying, not the number of people who died over the number of people who given treatment, and you'll get a number interpreted as either halves the risk or the odds of dying versus living. Now, what you need to know is when to use the odds ratio and when to use the risk ratio. The odds ratio is much more robust mathematically, because the odds of dying is 36 by 496. The odds of living is 496 by 36. But the risk of dying is 36 by 496. But the risk of being alive is 36 by 532. And the risk of being alive is 496 by 532. It's a completely different number. So you cannot interpose them. Then the other thing is, you cannot use relative risk for case control studies, whereas you can use an odds ratio for any of these studies. But when you're using a relative risk for research trials and stuff, if you've got very rare outcomes, they're both similar. But when the event rate starts rising to about 10% or so, the odds ratio overestimates benefit. So to give you an example, you got 200 children randomized to 2 drugs. If the outcomes are rare, say 4% and 6%, the relative risk and the odds ratio are virtually the same, and the confidence intervals are the same. But if you have outcomes which are, say, 40% and 60%, you will find the relative risk is the same. The confidence interval is more narrow because you have more numbers, but the odds ratio is an overestimate. And it's not near the same as the odds ratio when you have rare outcomes. So what you have to do in this situation is to convert the odds ratio to a relative risk. There are many methods, but the commonest method is to take the square root of the odds ratio. And you will find it is 0.663, which is similar to the 0.67 of the risk ratio. So these are nuances that you need to know when you're understanding what is the evidence. And clinicians intuitively understand relative risk better than they do odds ratios. So let's just translate this into some real terms. Somebody asked me to help them, tell them whether you should give a short course of corticosteroids to prevent premature delivery in high-risk mothers. And I found this study, Liggins, which gave us this data on mothers randomized to get steroids and not to get steroids, and these are the outcomes. So we can calculate the risk ratio from this outcome. But also important is to know what is the actual difference in the number of neonates who die. What is the absolute risk reduction, not just the relative risk reduction. So that you get by subtracting one risk from the other. And then you can derive your number needed to treat, which is the inverse of the risk reduction. And you need to put that all with your confidence intervals, which you can calculate using a formula, or you can put into software. But what we need to do is to be able to translate this so that we can communicate this information to other people. Right? So risk ratio 0.61 means that this particular intervention will reduce the risk of premature delivery and a person dying by 39% compared to not taking steroids. It can be better. It can be about 59%. At the very least, you'll expect a 10% reduction. And the risk difference is basically, with steroids, you can prevent 4 less neonatal deaths per 100 births than without steroids. You multiply 0.44 into 100 and round it off. And do the same for the confidence interval. And the number needed to treat to benefit is the inverse of that. Okay, so tells you that you will need to treat at least 23 mothers with steroids to prevent 1 neonate dying. It could be from 12 to 104. But there's also another bit to keep in mind. What are the relative and absolute effects? Relative effects, you can get a relative risk for death of 2 when comparing 1 out of 10 deaths versus 1 out of 20 deaths, or 1 out of 1,000 deaths versus 1 out of 2,000 deaths. But the absolute benefit differs. And if you look at it carefully, you'll see what are the differences. The control group risk, the baseline risk in the first example is 1 out of 20. That means without the intervention, the risk of dying was rare, was common. And when it is 1 out of 2,000, it says even without the intervention, hardly anybody dies. So when you've got a very low baseline risk, your absolute benefit is going to be not very high. When you have a high baseline risk, that intervention will actually have some benefit on you. And this will affect what is called your number needed to treat. When you have a low baseline risk and a good intervention, yeah, your number needed to treat will still be high. So relative risks tell you what is the actual difference in the two interventions. Your absolute benefit is who do you give this drug to? In which population do you use this intervention? That will determine the absolute benefit of that drug. So if you look at number needed to treats now, when I gave you the difference, 1% difference between the two, your NNT is 100. But suppose I had given you a difference where there's a 10% difference between the two, right? Your NNT comes down. And this is important in clinical practice because we try to calculate the NNTs. For diabetes, to prevent neuropathy, it's 15. To prevent acute myocardial infarction after 5 weeks, it's 20. But when you look at hypertension, it all depends on the baseline risk. If you want to prevent death, stroke, or MI with antihypertensive drugs for 5 years, it depends on what was the baseline risk. When the baseline risk is low, you need to treat many, many, many more people. So this is what happens when we try to market drugs. Continuous outcomes, you have another problem. They're very, very commonly used. And in fact, there was a very controversial study. We looked at studies given to the FDA for approval, and they found that the response rate of 80% was there in both the arms, right? And the mean difference between drug and placebo was 2 points or 1.8 on the scales, depending on the length of the scale. And so we all know that there's a high placebo difference. So the big controversy was the FDA said 1.8 points on the Hamilton Depression Rating Scale is enough for us to approve a new drug compared to placebo. The NICE guideline says, no, 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 you need 3 points. I'm asking you, if you were depressed, severely depressed, and your score was something like 43, you can reduce your score to even 20, but to be non-depressed, it has to be less than 8. So you can get statistical significance with these, continuous variables, but we do not know how clinically important it is. Clinicians don't use rating scales. Clinicians think very much like the clinical global impression scale. Yeah, how much of improvement? That's how we think. So what these researchers did was they combined from studies where they've done both these kind of scales together to see what are the equivalent of in reduction in one scale to be able to get you a reduction in this scale. So you can now anchor your results to severity, as well as to see what is minimally improved on one scale compared to what is markedly improved on another scale. So whenever you're using continuous outcomes, you need to be able to link it with what something clinically would be considered significant. So this is what I was trying to tell you in terms of saying, what is the evidence? Now the next question is, can I trust the evidence, right? And to see how you trust the evidence, you need to know what actually can take away your trust from the evidence. There are two factors. One is systematic errors, which is bias, and the other is random error, which is chance, which affects precision. So random errors, you know, you can find out by confidence intervals and p-values. But narrow confidence intervals can give you a false sense of the validity of the outcome if there is bias. And you cannot detect bias by p-values. So every study design has certain ways in which it's done which can increase the risk of bias. And bias can arise due to any stage in your research project. You have to be very careful about how you can prevent that. And when you're looking at it, there are many scales that people use, the Haddad scale and many other scales. None of them are valid. Many of them are actually looking at external validity and not internal validity. So please don't use any of them in randomized trials. What you have to look at is what actually has been proven to make a difference in studies to increase the risk of bias. So we have now certain domains that we consider that if you don't report these properly or do them properly, there is empirical evidence to suggest that it is associated with wrong results. So in today's world, the recommended tool to look at risk of bias is the ROB2 tool, which is a Cochrane's revised tool to assess risk of bias. And it's slightly different from the traditional ways we are looking at it, but it gives you this how to actually go about doing it and gives you instructions on how to make the judgments to arrive at an overall risk of bias on these studies. And if you're doing non-randomized studies, any kind of observational study, the preferred tool to assess risk of bias is Robbins I. Okay, both of these are freely available with a lot of instructions on how to assess risk of bias. You need to please get familiar with these tools. And also be familiar with all the reporting guidelines that are available on the Equator network, because for every design, there is a reporting guideline which tells you what is expected of you when you submit for publication. So unless you know, if you can incorporate all that into your protocols, it decreases your chances of getting a publication. And in fact, yesterday, the new version of, it has been reported this year, the published version of the new consort guidelines was released. So these are important ways in which you can equip yourself as researchers. Now the next question is, can you use this evidence? External validity. But before you ask this question, you have to ask yourself, have you got all the evidence? Because you've got one study that you assess, no? Because the real world is unfortunately not so good. So I told you the results of ligands. I'm presenting the results to you graphically, where the vertical line is a line of no difference, and the horizontal line encompasses the risk ratio of 0.61 and the width of the confidence interval. With one look, you'll know this study is effective. But I found another study which has actually got same PICO statement, but smaller sample size, so wider confidence intervals. So now I have one study which I'm sure will help, and one I'm not sure. So this is about the time when I discovered the logo of the Cochrane collaboration, which is again looking for studies on corticosteroids, and I found 7 trials of steroids in the systematic review, 2 of which favored corticosteroids, and the remaining were unsure or may cause harm. So the Cochrane's way of arriving at this question was not to do a vote counting, where 2 versus 5, where the 2 large studies with narrow confidence intervals are given the same weight as the others, which have got low sample sizes and wide confidence intervals. So they weighted average of all the studies is what you do in a meta-analysis, and that showed that steroids help lice. But the systematic review not only had outcomes for neonatal death. But what happens in a systematic review is you can pool results from numerous trials and you can get results for various other estimates which are important for having health outcomes. So these are ways, and we start advancing from individual trials to arriving at decisions we can make for policy. Now, I have a lot of stuff to talk about, but you can understand why over the years people have started saying that the best evidence comes from systematic reviews of RCTs. But that's really not true, because it depends on what is your question. If your question is about etiology or diagnosis or prognosis, there are other study designs which are better able to answer those questions, and a systematic review of those study designs gives you the best evidence, right? So you need to be able to realize that in practice, if you're not trying to look at cumulative evidence, you can have a lot of harmful effects. So this is a very seminal study published in 1992. Looks very confusing. Take a look at the left of this graph. What you see is a forest of lines. Each line in this forest plot shows the odds ratios and confidence intervals of 33 trials done over 30 years, randomizing more than 36,000 patients to intravenous streptokinase or no streptokinase to prevent death after myocardial infarction. 6 trials only showed clear benefit. The rest were not they were too small. But when you pooled the result, you were clearly able to show that streptokinase saved lives. Now, what this author wanted to know was, did we require 33 trials, 36,000 patients in 30 years to come to this conclusion? Could we not have known this earlier? So he took each study from the first one and kept adding it year by year by year by year to see what is the pooled evidence for that year. And he found that by 1973, with only 7 trials, randomizing 2,400 patients, you knew that streptokinase saved lives. But the world kept randomizing. In 1986, GC1, 11,000. 1988, ISIS, 17,000 patients. So if you were in an ethics committee in 1973 and you had the pooled results from the first 6 trials, it's highly unlikely you would have approved the remaining trials. Why? You're randomizing half of them to increased harm. But while we were doing this in the world of research through our ignorance, what was happening in the real world? No textbook was recommending thrombolysis after myocardial infarction till 1980, although we had the evidence many years before. In fact, what were they doing? They were recommending prophylactic lidocaine, which the cumulative evidence was showing it doesn't help, it may even harm. So this led to, all of this is the reason why Cochrane came into being, right? Advice on some life-saving therapies was delayed for more than a decade, while other treatments have long been recommended. So this is the reason why we need to have a clear look at all of this stuff. Now I'm going to skip a few slides and come down to the whole issue of guidelines. Now the current recommendation as far as guidelines is concerned is that any guideline that is made needs to have, it should be based on a systematic review, and So what I want to point out is that in research, what you're doing in research will get involved in a process where people want to see whether we can use it to make a guideline, and that process then gets used in a thing of guideline development. Now I have a lot more stuff that I want to talk to you about, our research synthesis, but I think I just wanted, as far as your work is concerned, when you're doing research, you need to know that everything that you publish has to be, that you do has to be accompanied by these considerations. What is the evidence? Can I show that this evidence is actually going to be clinically beneficial? And have I used methods in my research which can minimize bias? So your results can be used by other people when they are trying to do guidelines for the country. Now the problem often is that when we are trying to do research, we ask questions. What is the evidence for the treatment for Vivax malaria in the country? Fortunately, in some of these disciplines, we have found studies from India, right? Very often, we will find we don't do the relevant studies. So when you're designing research, these systematic reviews will help you because apart from your priorities, you may have priorities. You need to see any of your priorities, is there existing evidence from a systematic review that we can use to make a kind of a decision. So I'll give you an example. And then what happens is that you can use that evidence to actually look at your own results to see, should I use that evidence? There was a time when the government of Ghana was actually trying to revise their essential medicines list. And one of their problems is malaria. And they found that the WHO had come out, Cochrane had come out with a recommendation which is approved by WHO saying, if you want to treat children with severe falciparum malaria, you should use intravenous artesunate compared to quinine. Now in Ghana, quinine is what they use. So they called WHO and together they had this big difference and found that quinine and the WHO evidence very clearly showed from trials of more than 4,000 children done in parts of the world that IV artesunate reduces about 22 to 30 deaths per 1,000 or whatever. But their problem is this. They are used to quinine, they have quinine, they make quinine, they know how to use it, it's cheap. IV artesunate they don't make, they have to import it through Gavi. It is very expensive, and if they use IV artesunate, it will take a lot of their health budget. So they made the decision that although IV artesunate is shown to be much more effective than quinine, quinine is also effective. And we need to be able to, if we start using artesunate, we will lose many more children to some other thing which we cannot fund. So the point I'm trying to make is, if you all in the Northeast want to set up your research priorities, it's good to find a list of all the stuff that you all think are important. Look for systematic reviews which are available there. If not, look for trials. Do the systematic reviews from what is available evidence. Then design your next set of questions using the methods which are all the guidelines to devise your protocols and do your research, and see how you can then look at routine clinical data, collect all your data to publish it. I wish I had a lot more time, but I know that we started it a little late, and I'd like to hand over to my next speaker so that over the next few days we can answer all of your questions. My email address is prataptarin@gmail.com. I'll share it to the organizers. If you want any more information on all this, I can help you. Thank you.
Thank you so much, sir. Thank you so much, sir. If there's any question, you please note down, and we may open the question and answer session just before the lunch break, or otherwise we would intimate to the resource person, and then we'll have a way to answer all the questions. So please kindly note down the questions we have, and please hold it for some time as of now. Thank you so much, sir, for introducing to us evidence-based medicine and the importance of good evidence in health research. It has been an eye-opening for us in many ways, and you have raised the curiosity at the high level, and we cannot ask for a better first session than this. Thank you so much, sir. further, we would like to hand over a small gift as a token of our love and gratitude to you. So, sir, I would like to request you to kindly come forward. And to do the honor, I would like to request Dr. Subarna Roy, sir, to kindly hand over our small gift to our esteemed resource person. Now, with this strong foundation and background, we would like to move on to our next session, which is on research questions and framing of hypotheses. To speak on this, I would like to invite Dr. Sanjay Juvekar, sir. He is a consultant research in the K&M Hospital and Research Institute from Pune, and also a professor of anthropology in Savitribai Phule University, Pune. Sir, please take your time.
Thank you, Hav. Thank you, Hav. Can you put on my presentation? Great, thank you, Pratap. This was really great. So now let's go to the little bit of basics of it. You've learned in the last 1 hour, fantastic way to see what you want to do and how the evidence would be useful and which of the evidence you generate will not be useful. Pratap, in fact, has brought out some very important thing. In my presentation, we realized that what he mentioned, why that is extremely important. So I'm going to talk about the research questions and objectives as well. Although you mentioned how that I should be talking a bit about hypothesis, but really I'm not going to really spend time on hypothesis much, but let's focus on the research questions and a bit of objectives. Before we go to that, we also need to understand the basics or the theory behind the research itself. And this is very important for all of us. When you talk about research, what are you talking about? It's primarily one individual begins with understanding something. If it's an individual beginning, what it means, it's about the ontology. It's your own perception. If what you understand the reality as you as being a person and the nature of knowledge that you possess. Based on that, you think something needs to be done, whether bad, good, how, etc. So that is what begins with what. And how do you do that? It's the epistemology. The entire research is embedded in these three things: ontology, epistemology, and the axiology. I'm not going to go into the greater details of this, but you need to understand that when you are doing research, these are the three terminologies which you need to really remember about. And what the epistemology means, it means the approach to the knowledge. And then about the axiology, which means the theory of value. And these things taken together actually form your basis. And that's where you need to do. And if you're going to the next, suppose you just look at this bulb, what do you mean by this? If you want to understand what do you mean by this is whatever is your understanding based on this. So many things will come to your mind. There is a need for investigation. There is a need for some inquiry. How? How will I do that? How will I measure that? That's the outcome, aim, objective, question and answer. So many things coming into your mind as a researcher. If somebody asks you to just look at it and frame a research. And for this, let's go to a couple of examples. Just a couple of examples I'm going to give. Does the new vaccine reduce the incidence of pneumonia in children under 5? This is some research question that somebody has in mind. But is this the way the research question has to be written? Maybe this could be written even better way. How? If you bring in to evaluate the efficacy of the new vaccine in reducing pneumonia incidence in children under 5. So this is just a little better way of writing the same research question. Let's look at one more example. What is the effect of XYZ on hypertension? That's all. But can we write this in a little better way? To assess the effect size of XYZ on hypertension. So we are bringing in more meaning into your research question. And what is that meaning we are going to bring into your research question is what we are going to later on learn in this session. A typical research proposal. Now I'm going to take you to a research proposal in general. Now these are the things: title, aim, research question, objective, outcome, endpoints. You may have other things like the background and the rationale and the novelty. These are the things which you always, often when you go to write a research grant, these are the things that are asked for. But remember, many a times the grant proposal give you very little space to write. And if you are given very little space to write, this is what you need to keep in mind. So these are the things: title, aim, research question, objective, outcome, and endpoint. If you keep these in mind, your proposal will be complete. Doesn't need to have a rationale and everything every time if it is not asked for. And even more important in any writing research is about the title. How people say that a good title should be specific and descriptive. It provides key information about the research topic and the study design as well, inbuilt in the title itself. Just an example: impact of exercise on type 2 diabetes management, a randomized controlled trial. I'm just taking one of the examples ahead as we move ahead. Okay? Now let's come to the aim of the study. Before we go into the research question, I thought, because what happens is, if many of you, rather most of you, when you introduce yourself, you've said that you have done research. Many of you are professors, assistant professors, associate professors. So everybody has been teaching tons of students in the last few years, whatever you have worked. So you have been doing research. That means what I'm going to talk now is nothing new to you. And some of you also mentioned it's just refreshing your knowledge. I think that's the right word. Here we are here to refresh our knowledge, but little going to beyond that. So let's try and understand what aim means. We have seen a lot of proposals. You write the title, the same is the aim, same is the objectives. So there is no difference between the three. But yes, there is a difference, clear difference. The aim should clearly state the purpose or goal of the research. And just keep this in mind, and also when we go to the research questions, keep those things in mind, because there is one important slide towards the end which probably sometimes also confuses people, but I'm going to come to the last slide, very important. Provides a clear direction for the study. The aim itself, it articulates what the researchers intend to achieve or investigate through their research work. That is what an aim should do. It serves as a guiding principle for the entire research process, helping to focus the study objectives, design, and the methodology. That means writing your aim should lead into the further writing of your research proposal. Should be very specific, relevant, and achievable, providing a framework for the research questions and hypotheses that will be addressed during the study. Furthermore, just look at the example. It is to investigate the effectiveness of a community-based intervention in reducing smoking prevalence among teenagers. I'm just giving you these examples. I'm not going to ask you. Usually, if it is a 2-3 hours, then what we do is we ask you people to also frame research question as examples and then move forward. But we know, due to lack of time, we are going to be just reading what I'm written as questions, example. So the aim should include the PICO. Okay, that is how it should be. The patient, P stands for patient. It should include patient, population, or the problem. Just remember these things for now. Some of you might have written PICOs for your proposals previously. Some of you might be writing in future. Intervention includes the exposure, diagnostic test, prognostic factor, treatment, behavior, etc. It depends on what kind of the trial you're doing, what kind of the study you're doing. It is not necessarily applicable only to the clinical trials, although it was initiated, PICOs were initiated for writing the clinical designs or clinical trials. Comparison includes the placebo, standard care, non-exposed. That's why all the examples, what it includes are beginning with what is there in the clinical trials. Outcome includes the clinical outcome of interest or the diagnosis. And when it comes to effect size, now there is PICO plus E. There is recently coming PICO T also. So we are advancing as we advance in the research also. So what you need to do is, let us see another example where you have to rearrange the sentence to make it more readable when you are writing the PICO. Now look at this example of a PICO. Simple. It mentioned population is children, intervention nutrition program, another nutrition program, see, and health improvement. So is that enough? Can we write it a little differently? Can we write it a little better, make it a little more meaningful? And to do that, here it is. You say it is adolescent girls 10 to 19 years of age in rural India. That is your population. You explain your nutrition program a little further and say that weekly iron and folic acid supplementation. So that makes a little more sense. It gives more meaning to your research that you are proposing. And what is the comparison? It is a standard diet without supplementation. So now you are moving to the next level and trying to understand what is the outcome. It is the improvement in hemoglobin levels after 6 months rather than just saying health improvement. A poorly written would be saying just health improvement. Now this is one example. Let's go to another example. People with diabetes, new diabetes treatment, no intervention specified, and better health outcomes. Is this enough? Can we write it even better? See, people may write only this much, but remember, if you have to be more meaningful, you have to be more specific, and to bring in that specificity, you go here. Adults with type 2 diabetes, instead of just saying people with diabetes. So you're specifying which diabetes patients are you looking at. Continuous glucose monitoring, isn't it? Then you are saying the comparison is with self-monitoring of blood glucose. And what is your outcome? You are looking into reduction in HbA1c levels over the 6 months of period. So now you are becoming more specific in your objective. So this is what it is. Now I'm coming to just 2 or 3 slides about the research questions. What it means is a research question should be clear, concise, and it is a focused inquiry, and it is specific and answerable in the context of your research. And these are the important things. If you remember this, I think you will write the right research questions. But what it should have, it identifies the topic of your interest. Then it specifies what the researcher, what you intend to do or to investigate. It provides a clear focus for your study. That's important, and guides the selection of appropriate research methods and data analysis techniques. To some extent, this is more applicable to the clinical trials and not necessarily epidemiology studies, and it aims to address gaps in the knowledge or contribute new insights to the field under your study. So keep this in mind. So just a couple of examples here. What is the impact of weekly iron and folic acid supplementation on hemoglobin levels among adolescent girls in rural India compared to no supplementation? So we have started initially, and the same 2 examples we are going ahead. The next example of a research question for the previous work that we have done so far is, does continuous glucose monitoring lead to a greater reduction in HbA1c levels compared to self-monitoring in adults with type 2 diabetes? Now the same examples we are going to take right till the end. Thank you so much, Pratap. You mentioned this, and this answers, or this actually substantiates what Pratap mentioned. How crucial is your research question? So Albert Einstein said that most of his time he will spend in just, I would prefer spend the first 55 minutes determining the proper question. And that's what Pratap was trying to tell. You spend more time in finding out which is your right research question. Once you have the research question clear, you can easily have your methods, because you have been trained for writing the methods. The most important thing is getting that right question. And I think this is very important. Please remember, so what happens is people, whenever you start writing a research proposal, I have invariably seen that people start with, what is my aim? They start with aim and objectives, and then they suddenly think that, oh, I need to also go for the research question. That's not right. So start with your research question in mind. However you may write. So writing styles are different. Sometimes you start with hypothesis. Sometimes it is also dependent on a lot of the funding agencies. Some people want only a hypothesis-driven research, especially when you're doing your PhDs. Invariably, all the theoreticists would start with your hypothesis. Whereas some funders would say that we want a research question, and then you address your research question through your methods. Then you have your objectives. But best would be to start having a research question in mind. Whichever way style of writing, depending on your funder, you may start, or depending on your call for proposal, you may start, but have your research question in mind first. So what is a good research question? That research question should pass the so what test. This is very common. I'm sure as you have been teaching, many of you, you will be knowing all these things, but let's revise. What does that mean? First, you're going to try and find out, will the research question lead to useful information? If your answer to this is yes, it will lead to a very useful information. So what? Then you ask the next question. Will the outcome add to or change existing knowledge? So it is going to it is going to lead to some useful information, and then you answer yes, yes. It will add to some existing knowledge, so it will change the existing knowledge. Even if it does that, so what? Ask the next question. Will it help guide other researchers? So it is going to give some information, it is going to add to the existing knowledge, it's going to change the existing knowledge, and will also guide the researchers. So what? That's what again Pratap mentioned. So the presentation what he made can be easily linked to what it says. He gave a lot of examples where the research just ends with the publications. It is only useful to the researchers. So what if it is useful to the researchers? Ultimately, that's the last so what. Will it provide valuable insights to the concerned policy? And that so what is more important. Only if you read to this place, if answers to all this is there with you, go ahead writing that research question. I think that's what you all should keep in mind. So, let's go to the examples of some research questions now. I'm just giving a few examples of the time. How to use community engagement to improve vaccination in children. This is a simple example of a research question. Can we write it in better manner? What are the most effective strategies for promoting childhood vaccination uptake in low-income urban communities? Now look at this. If you go to the so what, 4 so whats, will it answer? Yes, the second one. If you go to the first way of writing, how to use community engagement to improve vaccination in children, probably the question itself may not answer all the so what. The second way will answer. Let's look at the other, how does access to garden improve mental health? Simple, how does access to garden? Will it answer all the so what things? Probably not. Can this answer? How does access to garden space impact mental health outcomes among the urban residents? Now it makes more sense. So these are just the examples for you to keep in mind. You may have, all of you have different areas of interest in mind. So keep that in mind whenever you are going into your thing. Just one slide about hypothesis. And if you have gone through the books like Margaret Mead or Good and Hat or Pauline Young, this describes hypothesis very clearly. A proposition which can be put to test to determine its validity. That is what this hypothesis means. It is, what is hypothesis? It's predicting the relationship between two or more variables. If you are writing a hypothesis, keep these things in mind that it is based on prior knowledge, observation or theory, which means you have to go through your literature a lot, read through it. Not necessarily, sometimes hypothesis started with whatever you would have gained your knowledge over the period of time and you just start. But it should be documented, and that's why going through your literature is very important. And why is this hypothesis important? Because it provides direction for your research. When you start a hypothesis-driven research, and hypothesis-driven research is more useful in your PhD thesis, or if you are already doing some work and you have some evidence and you're sure that if it is done in a different manner, it will be useful. So then it provides direction to your research, and it helps in selecting appropriate methods and analysis. But quite often, if you see people just write their hypothesis and end with it and start with a research question and aims and objectives writing. And that's the place where people make a mistake. If you want to write your hypothesis, you should know that never write only your hypothesis as just one hypothesis. Every research that drives or hypothesis-driven research must start with your null hypothesis, which assumes no relations or no effect. Just there is no association between maternal education and antenatal care visit. That's a simple null hypothesis. Unless you write your null hypothesis, your alternative hypothesis does not make sense. And that is why you must have both together. So alternative hypothesis assumes there is a relationship or effect between what? You look at the same example, higher maternal education associated with more antenatal care visit. So I'm going to stop about the hypothesis here because there are 3 or 4 very important things which I need to talk to you before we go. Now going to the objectives. No, you also why I am also telling you the objectives while I am talking about the research questions and hypotheses, because unless you understand what are objectives, you really cannot really differentiate between the research questions and objectives. So this is very important. Objectives breaks down the broader aim of the study into concrete actionable steps, which means you should have aim in mind, only then you go for the objectives. So, and guide the research process, help achieve the overall research goal. These are the primary characteristics of the objectives. Objectives are formulated based on the aim of the study. Then it should provide clarity on what aspect of research will be investigated, measured, or evaluated. Then objectives also serve as the building blocks for the designing the research methods, data collection, procedures, and even your analysis plan. Unless your objectives are clear, you really cannot move to that. And just a couple of examples. To assess the change in BMI among participants 6 months of dietary intake. So that is what is an objective. Or to examine the association between dietary patterns and cardiovascular health outcomes. So I'm just giving example, reading out examples for you. Look at this aim. It's a broader aim of one of the studies. This is an example to test the clinical cost effectiveness, sustainability at 6 months, acceptability and implementability of center or home PR delivered in low resource centers for people with CRDs compared to the usual care. Now this is what is a broader aim given in a funding agency, by a funding agency, okay? Now this is given to you. You cannot change your aim. You only have to go further and write your objectives. And that is what you will be funded for if you want to write those. So how do you write your objectives? Look at the primary objectives. I'm purposefully giving this example. The first one, in people with CRDs, compared to usual care, does center PR or home PR improve functional exercise capacity? Now this is what is an objective written. Remember all of you. Then second one is, does supervised home PR achieve outcomes that are non-inferior to center PR? And then you have the secondary objectives as well, which are in people with CRD, is the impact of center PR or home PR. PR is pulmonary rehabilitation, sorry. Some of you may not know. So sustained at 6 months, and does center PR or home PR lead to changes in healthcare utilization, patient expense, and work productivity over 6 months? And lastly, are center PR or home PR programs acceptable, feasible, and implementable? So these are the objectives written. Now remember, usually when we write objectives, you never have objectives as questions. Now these look to be research questions. Aren't these research questions? For many people, this will look like research questions, but these are stated as objectives. Now let me tell you, I don't want to confuse you all, but you all should also remember that because we are living in a state where, whether it is intramurally funded by your own institution or extramurally funded by any institution across the nation or outside the nation, if you're applying, you need to understand the different styles of writing the same thing. And fortunately or unfortunately, the dilution of all the definitions, the writing style has made this problem. Now the objectives are written as if these are the research questions, but primarily this is one style which is more acceptable to the UK style of, you write to Wellcome Trust, you write to the DFID and all, so these styles would be accepted. But when you are writing to, say, our own institution like ICMR or DBT, please do not use interrogative sentences as objectives. because we believe in what is theoretically we have been learning from all, and we know that these are statements and not interrogative statements. Interrogatives also lead to some research questions. So that's why don't get confused between the two. As long as you are very clear about this thing, you should know. But then this is how you will find, because otherwise you'll say, oh, that fellow said, Sanjay said that it is a statement, and here we have so many questions. Are these research questions or objectives? So don't get confused. Objectives have to be smart. I'll give 3 references. I haven't written here, but Prashanta, I will share the references for the PICO, SMART, and one more terminology I have which I'll be using. So the objectives have to be smart, measurable, achievable, relevant, and time-based. Just keep this in mind. Now let us come to one more thing, outcome versus endpoint. Now again, the endpoint is a term which was very, very commonly used in an experimental design, an experiment, or in a clinical trial, when you have some intervention and you are expecting something as the end of that. Behavioral science also nowadays have started trying to understand, can we have some endpoints? But behavioral changes always take more time, and maybe sometimes years or decades, so you don't look forward to measuring your endpoints in behavioral changes studies. But otherwise, usually in clinical studies, you do that. So what does it mean? Outcome refers to a broader consequence of an intervention or an exposure, whereas endpoint is a specific event or outcome used to measure the effect of the intervention. Outcome represents the effect or impact that the intervention or exposure has on participants' health, behavior, or other measurable variables, whereas endpoints are often predefined and serve as markers for success or failure of the study. I believe you're getting what you have written previously. You might have written, especially for those who guide the DNB students or the MD theses, I think you don't keep these things in mind, but these are the things you have to keep in mind. So when you teach your students, keep these things in mind, because theory behind what you do is extremely important, then you do it right. There are just a couple of examples here. Changes in blood pressure, reduction is in smoking prevalence, in quality of life, or incidence of a specific disease is about the outcome endpoint, and same example for the endpoint also. So let me go to the next one. Finer. Now this is about a research study in general. There is a good reference for this also. I will give all these 3 references to, but just remember, a study as such should be feasible, interesting, novel, ethical, and relevant. What it means, adequate number of participants, adequate skill mix, is the project manageable within the time frame and the budget? These are the things you have to keep in mind while you are starting write your research studies. So look at the feasibility more. If you look at the ICMR call in particular, because we are here for the ICMR call, you will realize that every time it is very explicitly mentioned whether it is feasible, isn't it? That's why these things are very interesting. Will the answer be of interest to something? Interesting doesn't mean whether it is interesting for me, but whether it is of interest to somebody, either the policy or somebody, it should be of interest. Is there a novelty in this? Is there no previous answer to this question, or will the answer confirm, refute, or extend previous findings? So that is what you should keep in mind when you are writing a research proposal. Is it ethical? Will somebody get hurt during the study? If slightest answer is yes, probably you have to think twice before doing that. Is it relevant? Who will benefit from the answer? People at large, policy, or future research? Somebody should benefit, but when you are using public money, try to ensure that it doesn't benefit only the researchers. And if you're doing a PhD for academic reason, okay, you say that, okay, it leads you to other research, perfectly fine. But don't think that when you are using public money for research, it should really lead to some policy change. This table probably is last but one slide, but everybody, I would suggest, now this was, you can change these things also depending on your research, but remember I just made it yesterday, because while looking into my presentation, I thought what is most important. I think if somebody understands this table very well, you are done with your research question understanding also, or even for that. I'll just go through this table in little more detail. Look at aim. what is the definition of, so I'm going to go vertically. You can go horizontally, but going vertically will make you understand this better. A broad statement of the overall purpose of the study is the name. Then what is the objective? See, now you will know, when you go through this, you will know what is the difference between aim and objectives and research question. Specific steps or components to achieve the aim is your objective. Now what is your research question then? A focused question the study seeks to answer. And that's next, you go to the hypothesis. What is the hypothesis? A testable prediction about the expected relationship between the variables, and the outcome is the end result, or what the study actually finds or measures. Now if you go through that, let's go to the next, the purpose. What is the purpose of writing the aim? Look at this. It's to define the general goal or intervention of the research. Likewise, if you look at the purpose of writing the objective is to operationalize the aim. You have to so the way you write your objectives have to be operationalizable. How do you write your research question? To guide the study and determine what data needs to be collected. That's how you write it. If you write the purpose for the hypothesis, it's just to be tested and validated or refuted through your data. And likewise, the purpose of writing an outcome is to show the effect or result of the intervention or the exposure. Coming to the next column, how do you write? In what form do you write the aim? It should be in the form of broad, overarching, and statement should be written as aim. Whereas when you write the objective, it has to be specific, measurable, and actionable. What specific actions you would be taking. And when you are writing research question, it should be clear, focused, researchable question in an interrogative manner. When you are writing in what form do you write hypothesis? Declarative, testable, and statement. And that's why the definition of a hypothesis, it is a statement. It has to be a declaration. And how do you write an outcome is a measurable variable or a data point. Now look at the example. Now this example will clarify all these things. Example is to assess the impact of antenatal care on maternal health outcomes. This is your aim of the study. Now you want to write the objective. You write it being a little more specific to determine the number of ANC visits during pregnancy in rural areas. That's your objective. One of the objectives. There could be more also for the same thing. A research, what are the barriers to regular antenatal care visits among the rural women? And hypothesis for such a question could be, women with higher education levels are more likely to attend 4 or more ANC visits. Now this is probable hypothesis. You could have different hypotheses as well. And outcome will be percentage of women completing 4+ ANC visits, maternal complication rates. Now, likewise, whenever you are writing a research proposal, have this table in mind, keep this table in mind and start filling this table. If you fill this table for each of your objective I'm saying. Now there are various styles of writing. There are studies, there are call for proposal where you are asked to write different objective 1, 2, 3, 4. It's not your primary and secondary objectives. Every objective is primary, which means for every objective you may have to have your sample size calculation. For every objective you may have to have your different methods, which is fine. It depends on what kind of call for proposal you are addressing. But this is, you need to, for every object, whether it's primary or secondary, try to fill in this table, and I think you will be done with your most of the thing. And then you have to elaborate on each one of this. Your research proposal is ready. What you need to be add is only the justification, rationale and background and those sort of things, and your research proposal is ready. So that is why I wanted to take more time on this, and that's the thing. We know so much. Do we really go into, do we really need more? That is what you have to decide as a researcher. You want to understand more about the research questions. We could have separate session and have more about the research question itself, going into the theory of it, into the background of it, or whatever it is. I'm going to stop here. Thank you very much. I'm giving more time for questions now. I'm sure Bora is happy.
Thank you so much, sir, for shedding the light on a very important aspect of research methodology, which is on research questions and objectives. We came to know from this session that research questions should be formulated at the conceptual stage so that it becomes the guiding principles to frame concrete objectives and sound methodology. Thank you so much, sir. So I request sir to kindly come forward once again. We would like to hand over a small gift. So I request Dr. Subarna Roy sir again to kindly do the honor of felicitating our resource person with a small token of our love and gratitude. Thank you, sir. So lunch is being prepared right now in the next, in the same room where we had our tea. Just before that, a quick 1 or 2 questions for both the sessions. So firstly, for this session on research questions, if there's any quick 1 or 2 questions, we will not take more than that. So kindly, the floor is open to ask questions on research questions and objectives. Or from the first session as well, yes. Can we please pass the mic?
Sir, thank you so much for your thought-provoking talk and enlightening about the evidence-based research. My question to you is, do you think that we need to improve the reviewing system of our journal?
Yeah, I do. But the problem is that, you know, most of our journals are reviewed by voluntary people. They don't have time. So there have been many initiatives to try and improve the quality of peer reviewing. We've held workshops for peer reviewers to understand peer. In fact, AIM used to do that very often, where we would get peer reviewers to come and we give them articles to peer review, hands-on workshop. So definitely we need peer reviewers to be much better because they are the gatekeepers in one way. So I think not only that, clinicians need to understand these concepts. And I'm quite happy to come back again and do a much more detailed workshops on every one of these things. So that's clearly there. Yeah, you had a question.
Thank you, sir. I actually have two questions for you. First question is, there is an index number you defined as risk ratio, RR. So one of that examples, it was said that there is 2 drugs has been intervened. One is A, another is B. In one drug, out of the 100 child administered, 6 died, and in the B drug, 100 out of the 100 children, 8 died. So when we are calculating RR, if we and another was probably 8 out of 100. That.
What I was showing was that when you have an event which is rare, that means only 6% or, no, 6 out of 10, right? Out of 100, that's 6%. And 4 out of 100, that's 4%. Okay. Right. So relative risk there is what?
My question was, so if we put the data for A drug in the numerator and another data for B drug in the denominator, then this RR becomes less than 1. So if I change the order, then it becomes greater than 1.
Yeah, so it depends on, see, usually what happens is that when we're trying to say there is a control, okay, there is a standard of care or no treatment, that usually will be one of the control. Your intervention, your experimental drug is usually the first one. So when you're entering your data in, your experimental drug is on top, and your control is below.
Okay.
And then when you're looking at outcome, you're trying to prevent a disease. So you'll always look at it as death, not alive. See, what happens is, we are trying to actually give a drug to prevent a negative outcome. So the advice is to phrase it that way. So in which case, your 2x2 table, you will find your experimental intervention, control intervention, death, no death. That's a convention.
Another issue is, sir, when you said in one of your slides that either we can use it manually or we can use also software. Some user showed some example of a software using to calculate probably CI.
Yeah, basically the confidence interval. A simple thing I've done is downloaded one Excel sheet program. Excel, CI calculator Excel.
Okay.
So there you just go to the tab which says, look at the difference between proportions.
My question is, sir, which of those softwares are referenceable, citable?
This is citable.
No, because there are lots and lots of software that can calculate CI.
You can use anyone, it doesn't matter. You can use any software to calculate.
But not all software, for the same data, there are possibilities that two different software will show different values.
Marginally different. So what you need to do is reference the software, and the software will tell you what model they've used. They are marginal different, they're not very much.
Oh, thank you.
Okay.
I just wanted to add to that. Forget about the software. Do that if and only if you can do it manually. Software are only to facilitate you bring down your time of doing that. If you cannot calculate confidence interval using your manual work, probably you haven't understood that, so don't do that. So if it is beyond the scope of your education or your expertise, take help from somebody, but unless you know how and why exactly the interval is calculated or whether it is for anything, software are only to help you, assist you, and not really do the work for you. Thank you.
That's why actually, sir, asking that which one is citable, because
any other questions? I'm happy to ask even the most basic ones.
Sir, my name is Pratik, and sir, I'm a senior research fellow at ICMR, Dibrugarh. So basically, in one of your slides, you mentioned about this over-reliance on p-values data. Basically, what can we do to curb down when most of our algorithm actually depend on p-values, like say path recollection?
I don't see, it won't apply to everything. For example, you're doing some lab analysis. Now, I'm not sure how to convert that into absolute numbers. But when you're doing clinical research in terms of, say, diagnostic test accuracy or any kind of intervention effects, you get your p-value, no problem. But you also have to be able to also report relative risks or odds ratios or risk differences. Only then can people quantify the difference. Your p-value is not going to be able to quantify how effective it is. And your confidence intervals gives you a range of possibilities. That means you're pretty, a 95% confidence intervals means your study estimate is your relative risk. But it could be anywhere from here to here when you're trying to extrapolate it.
More and more association factors needs to be.
Yeah, whether it's association also. Yes. You need to be able to show it with your odds ratios, the relative risk, and your confidence intervals. Because if you say p-value is there is an association. How much of an association? That's what we want to know. No? So lots and lots of publications have come out saying that, this was significant. And if you actually look at the numbers, hardly any difference. It will not translate to anything in the real world.
Thank you, sir.
Thank you, sir. Just two questions we'll take from this side, and then we'll break for lunch. Sir, please go ahead.
Sir, I have a question. While, you're showing the review, so will you comment, you did not touch that upon, maybe due to time. Will you touch upon grade analysis?
Meta-analysis?
On grade analysis of a systematic review.
I actually only came halfway through my presentation. Then I realized there's such a lot I will tell you that I will infringe on other people's time. That's why I stopped. There's another half of that, you can have it. On meta-analysis and how to use systematic reviews, how to interpret a meta-analysis, sensitivity, everything is there, including the grade process on how to be confident of the evidence. I'll come back some other time and I can do a Zoom workshop for you. Yeah, you call me anytime. The next part of it.
Sir, excuse me, sir.
Yeah, last questions we'll take from this side.
So I wanted to ask you, for medical conditions, how do we calculate numbers needed for treatment?
Number needed to treat. Okay, I showed you a 2x2 table which shows, you know, the number of people who got a treatment in each arm, how many had the event, right? Now, each arm, say 10 out of 100 given a treatment, 10 people died out of treatment A, out of 100. The risk in that group is 10 out of 100. And in the other group, 5 out of 100 died. The risk is 5 out of 100, right? Difference between one risk and the other risk is your absolute risk difference. The absolute difference, right? The inverse of that is your number needed to treat.
So thank you very much, because you have rightly pointed out that statistically significant may not be related to the clinical significance. That has been also, I have been always talking about that sometimes statistical insignificance may have socially significant. But the problem is that in our social sciences, UGC has totally devastated the research area. UGC has totally devastated the research area because of the peer review journal's name. Most of our, I would say, junior researcher, they have been improved, right? Maybe promotion and other things without going through the inequality of the research. Because of which I would say I am very much into you that we had done a lot of harm to our quality of the research area. My question is, sir, who will bail the cat? That's the major problem. That's very interesting.
Did you, if I understood you correctly, sorry, and thanks for allowing me to talk. So if I understood you correctly, you posed the necessity or the importance of qualitative research against the quantitative research, which deals mostly with statistical significance. Was that the question? Okay. All right. Now,
see, I'll tell you one thing. I think they're complementary in many ways, right? See, we need to know what works and what doesn't work. We also might need to know why does it work and in whom does it work. So I believe that evidence is evidence. It depends on what your question you're trying to ask. See, even in meta-analysis, for example, there was a very landmark meta-analysis on evaluating whether DOTS for TB treatment is required. The problem is DOTS refers to a larger program involving policy and this, that, and the other. Unfortunately, they called it DOTS, which is direct observation of treatment. So the program got a larger event got defined by the name you gave it. So the systematic review was asking, is it important for us to supervise? Or if they don't supervise, will you get better outcomes? And the systematic review meta-analysis clearly showed from many, many studies that whether you take it yourself or somebody supervise it for you, real outcomes are not changed. But all the data was not consistent. There were some studies where it seemed better and some not. So some people decided, let's do a qualitative systematic review. They looked at all the studies where people who are going and taking DOTS treatment have been asked on their experiences in that. And very important findings emerged. In people in whom the diagnosis of tuberculosis is stigmatizing, which could be a woman, which could be somebody with HIV, they will not go to a DOTS provider. Right? So it helps us to understand the reasons for heterogeneity. You can do it in some kind of a meta-regression and all. But you can also do it through qualitative research. So I am not denigrating the importance of qualitative research. Each has got a place. That article, you should read that article, it's very interesting, which talks about saying who defines a disease. So if you take surveys and ask people, which of these are things you'd consider disease? Majority of people will say that some conditions are disease, but many people disagree. So the names you give it, what people consider in your language, what do you call this? Another very interesting example. I don't know how many of you heard of this anthropologist called, he's a very famous guy from Harvard. There's a book written about him. Paul Foreman, fantastic guy. And there's a book written about him called Mountains Beyond Mountains. And he's got a very nice anecdote, right? Now, what he used to do was he used to go to Haiti, which is a very poor, impoverished place, lots of tuberculosis, and he used to whack medicines from his institution, get donations, and give treatment. But then his team started saying, listen, you're going through all this trouble to give them treatment, they're not taking it. So they had a big discussion. Why are they not taking the treatment? So some people said, that's because you have a medical model of illness, which is bacteria caused this, that, and the other. And they have a different model that is caused by black magic or something like that. So that's the reason why they're not taking treatment. Another group of people say, no, that may be true, but also coming for treatment means they have to leave their work, they got nobody to look after their children, they don't have the money. These could be the reasons. So he conducted a trial where everybody was educated about the bacterial etiology of tuberculosis and given advice on treatment, side effects, and all that stuff. Then one group got the treatment and the usual routine follow-up. The other group also got whatever they needed to come for treatment, which could be a babysitter, bus fare, anything. And what he also did was, before and after, he asked them on what their belief systems were about tuberculosis, what causes it, all that stuff. And he found very interesting things. Obviously, the group that got these specific treatments did better in terms of adherence and cure rate also. But one of the findings was, he asked one of the women, who was an elderly woman, very dignified woman, who in the start of the experiment said, of course I know that tuberculosis is caused by bacteria. What do you think I am? Right? And she happened to be in the group that got the actual treatment plus support and stuff, and she was cured. Then he asked, okay, and I'm just checking again, what do you think causes tuberculosis and what do you think of the treatment? She said, now that I'm cured, I am going to go and get that witch who caused this problem to me. He said, how can you believe this? You told me in the beginning it's caused by bacteria, and now you're saying it's caused by black magic. So she looked at him, white man, very pityingly and said, are you not capable of complexity? Is your mind so dumb that you can only think in a linear manner, cause and effect? Multiple things can cause multiple things. So we need to realize in our cultures, there is a complex mind which accepts black magic as well as science. And we have to understand all of that if we really want to understand why sometimes things work and why. So I'm not discounting qualitative evidence, but you can't rely only on qualitative evidence.
Thank you so much, sir. We will continue the question and answer session in the post-lunch based on availability of time. Our next session is scheduled at 2 p.m. So let us all take collective responsibility to start on time so that we can finish on time. So lunch is being served in the hall on my right side where we had our tea in the morning. So have a nice time and bon appetit, and let us try to come back by 2. Thank you all. Hello, good afternoon everyone. Welcome back to the post-lunch session, and I hope you all have a good and full lunch. It's a special Assamese thali that we have arranged for you all. I hope you all enjoy it. Before we begin the session, I would like to make a couple of announcements. Firstly, all the slides and presentation PPT will be shared to all the participants. For those consent we get from the resource person, if we get consent from the resource person, whatever, the first two resource persons have consented, so we'll be sharing. And the upcoming sessions also, if the resource person have consented, we will share all the slides to you. And secondly, our account team is stationed there near the entrance. So all the participants are requested to kindly fill up their TADA and reimbursement claim forms during the break or after the session today. So our account team are here full time, and right now they're having their lunch, so they'll be coming back in another 10-15 minutes. So during the break, please kindly fill up those forms. Now we move on to the next session, a very important session indeed, on epidemiological study designs, sample calculations, and sampling methods. This session will be taken by Dr. R.M. Pandey, sir, retired professor, Department of Statistics, AIMS, New Delhi. With this, I would like to invite sir to kindly take his time. Sir, please take your time. Yes, sir.
No, this is fine. This is fine. Yeah.
Sir, if you want to use this, we'll just
Okay, fine. Good afternoon, everyone. And thank you very much for having me here. Actually, this session has a lot of disadvantages. One is, see, nice lunch, isn't it? So, post-lunch session always very difficult. And subject also is not very, right? Attendance also has, some of the participants may have gone to the rooms to take short nap. So there are a lot of disadvantages, right? So therefore, I don't expect that you all will understand what I'm going to say. But I will look at each one of you. If none of you are sleeping, I would think that I have done well, right? So that is my indicator for success for this session, right? So once again, thank you very much. The topic that is assigned to me for 1 hour. I have 1 hour, or Prashant? So I hope I have 1 hour time. I'll be taking some of your time. So the topic that is assigned to me is epidemiological study designs. That is number 1. Number 2, sample size calculation. And number 3, sampling. So these are the 3 things that I'll be covering, right? May not be in equal, but I will cover this. And I will just give you an overview. I'll not get into the details of all that, right? So let's see. You heard 2 sessions in the pre-lunch session, right? So this is just continuation on that. What is the beginning? What is the first thing in research? What is the starting point in research? It was emphasized in both the sessions. Research question, right? If you have identified right research question, like Einstein's slide, that if he had 1 hour and he will spend 55 minutes on identifying right research question, he can do it in 5 minutes, that answer. But we are not Einstein, but I would say if you have identified right research question, 1/3 of your research is done. Rest 2/3 is all technical, as Dr. Juvekar said. They're all technical. People are there to support you. People are there to help you. But nobody is going to help you on developing research question. So most critical thing is research question. जैसे हमारे भगवत गीता है, भगवत गीता क्या है? क्वेश्चन आंसर है. उसका क्रेडिट किसको जाता है? अर्जुन को कि लॉर्ड कृष्णा को? Arjun ko, because he asked intelligent questions. If had he asked a stupid question, to wo nahi hota. So credit goes to the one who asked right research question. And if the PI is good, if the study is done well, then you have an opportunity to get the right answer. Right? So research question. Research question is for what? Is for a defined target population. But we can never study entire target population. We always study a sample. Right? We always study a sample. We collect data, we analyze, and whatever we get, we extrapolate back to the target population. So the cycle is complete. Right? So the question sample. How should we collect our data? How we should enroll? All of those are part of study design. Right? How much we should collect? Should we enroll 100 patients, 200, 300, 500? That is basically the sample size. And how should we go about enrolling these many from that population? That is sampling. So these are the three things I'll cover in next 1 hour. So what is research design? As it was already mentioned, is a procedure and methods predetermined by an investigator to adhere to while conducting a research. Same research question I can answer using any of the study design. And the moment I decide on a particular study design based on my constraints, I will have to then follow all the rules and regulations of that study design. And there are various study designs, level of evidence that is generated is different. We'll see all that. Right? So this is the definition of study design. It was mentioned qualitative, quantitative, right? So we have two kinds of study designs, qualitative study design, quantitative study design. As Dr. Pratap said, in quantitative, we are interested in knowing how much. And in qualitative, why so much? On explanation part, right? And other one is mixed method, right? So what Dr. Vishwajit will be talking, implementation, that is mixed method, where basically both qualitative as well as quantitative. It is not that quantitative is superior or qualitative is superior, it is not all that, right? I don't think any study is purely quantitative, no. If you are doing a quantitative study, formally you may not be showing mixed method, but don't we, while preparing questionnaire, don't we do a lot of homework, lot of groundwork, you talk to experts, so you do qualitative part also. You may not be doing in a formal qualitative manner, but I don't think there is any study which is purely quantitative, right? You may, all of what questions to put, what all that is all basically you consult experts, that is all goes into qualitative. So both are, qualitative studies are not easy to do. They require a special skill. Quantitative studies are, आप नदी के किनारे बैठे हैं, कांटा डाल दिया, मछली पकड़ ली. That is quantitative, very easy. Qualitative, you have to dive inside and then from the bottom you have to pull out something. So that requires a skill. You need to swim. So qualitative studies are, one should not undermine. So that is basically, so what I'll be discussing is on quantitative studies, not on qualitative studies, right? So hereafter, whatever I'll be discussing, that will focus on quantitative, not qualitative. If you have attended any workshop, any session on research methods, or if I see any protocol on any subject, or if I see any manuscript from any discipline, I only look at these 5 terms. So if you have attended a workshop on research methods and don't use these 5 terms, you have wasted your time. As a biostatistician, I talk to everyone. How do I talk to? Only these 5 terms. I don't know their subject. I hardly know my subject. So these are the 5 terms that you have to remember. Research deals with variability. No variability, no scope for research. If you are doing a study in women, so in your questionnaire, will you have a question on gender? No. That's constant. So we don't deal with constant. We deal only with variables, which is variable. No variability, no research. And in any research, it does not matter which discipline, which department, what level, we always deal with only 3 kinds of variables. No 4th variable. Any discipline you take, only 3 kinds of variable. And those are, first is your outcome variable, in which you are actually interested in. Outcome variable is, so this is ABCD of epidemiology. If you want to learn music, Sare Gama Pa. If you want to learn English, you should know ABCD. If you want to learn research methods, this is the one. Basic principles of epidemiology. This is not community medicine. If this will apply to any discipline. So the only three variables: outcome variable, in which you are interested in. You may have one, you may have more than one in a study. Exposure, that is what is second variable. Exposure variable. And third is other factor. Any outcome you take, whether communicable or non-communicable, there will not be a single factor, single exposure. There will be a whole lot of them, and many of them we don't know. We know only few of them, and even those we know, we cannot collect data on all of them that we know. So exposure is actually exposure of interest. In 95% of the studies, we are interested in knowing role of one factor on one outcome. And all other factors, they become nuisance, they become villains. They are other factors. We are not interested in them. And those other factors will not let you know the true exposure-outcome relationship. So we spend maximum of our energy in research in those things in which we are not interested. I'm not interested in third factors. You take any condition, communicable, non-communicable, there will not be a single factor. So only three variables: outcome variable, exposure variable, that means exposure of interest. Exposure is any factor which has potential to influence the outcome, that is exposure. But here of interest is only one, right? So other factors. So first three are variables. Your other factors may have confounder, maybe your intermediate outcome, or you call it process indicator, or could be effect modifier. So all of those things are different, right? I am not interested in other factors. I am interested in knowing exposure outcome relationship, right? But again, bias, risk of bias. Bias, every research will have bias. Every researcher is biased. Why are you doing the study? Because you are convinced. You have done literature review and all that. You are convinced that this works. Now you want to show the rest of the world that yes, it works. You are biased. Everybody is biased. Bias is everywhere, starting from framing of research question to end, publication and all that. Research question itself is biased. You are framing from review of literature. Not all the work in the area is actually published, right? So you are framing from a bias. So bias, there is, as it was mentioned, there is no statistical tool to correct for bias. Bias you have to anticipate, and then you have to mention what steps you are going to take to make sure that the bias does not enter into the study. That is method section, right? So when I say, when you have done a study, say exposure outcome relationship is this, nobody is going to accept this. They will say, no, no, whatever you're saying, they will look for other possible explanation of whatever you're saying. And there are three other explanations, and that you have to rule out. Then only the fellow will believe that this is a true relationship. First one is, it could have been because of other factors. So that you have to convince that yes, other factors are not possible explanation of what I am saying. Perfectly fine. Then you have to explain that this is not because of bias. Still he will not believe. Then you have to say, he will say, but you have studied only one sample. This could have been your lucky sample. So then you have to show that this is not a chance finding. So whatever I am saying is not because of other factor, not because of bias, and this is beyond chance. Then only your findings will be accepted. So your protocol must address all of this, right? So these are the basic, this is ABCD, please remember this. Now there are various study designs. So this is what the pyramid that you have usually seen. So you have animal and laboratory studies at the bottom. This is what is the quality of evidence. As you go up, the level of evidence goes up, right? So at the bottom is animal and laboratory studies, then case report, case series. Then after that there are 4 studies: cross-sectional, case control, cohort and randomized control trial. That is what we'll discuss briefly. Those are basically, that's what you plan. Systematic review, meta-analysis, clinical practice guidelines, they come at very, very high level, right? So those are secondary research based on, so that is based on your filtered research. But primary data is these 4, and that is what we'll discuss. Now look at these 4, cross-sectional, case control, cohort and randomized control trial. You can divide these 4 studies into 2 parts in 2 ways. We'll go to that later. Now here says observational. cross-sectional case control cohort, they are observational. Why observational? Because you are not interfering with the outcome. You are not interfering, none of your action has any potential to change the outcome. There, that's why observational. In clinical trial or intervention studies, you are interfering and you want to see the effect of this intervention on some outcome in whichever way, right? So that is what it is. We'll discuss that. Now, suppose you want to know what is the study design. If you read a paper, you want to know what is study design. So ask certain questions, you will know the study design. First you ask, did the investigator assign the exposure? If yes, then it's a experimental study, intervention study, right? Then you ask, what is the manner of allocation of assignment? If it is random, it's a randomized control trial. If no, non-randomized control trial. So that is one side when the exposure has been assigned. That is easy. Go to the other side when the exposure was not assigned, right? If it is not assigned, that is observational study. Then you ask next question. Is there a comparison group? Will every study have hypothesis? Yes or no? Very quickly, will every study have hypothesis? Yes or no? No. Which studies will have hypothesis? Some people are saying like this, some people are saying like this. So we have, exactly. If we have comparison group, if we are comparing something with something, we will have hypothesis. And such studies are known as analytic studies. So analytic studies are those where we are comparing something with something, therefore hypothesis will be there. If you are not comparing, if you want to know what is the prevalence, no hypothesis. But if you say, is prevalence more here as compared to this, you are comparing, right? So you are right. So that is there a comparison group? If yes, then analytic study. Now you should see how participants were enrolled and what was the status of exposure and outcome at the entry point of every participant, right? So now you ask certain question. Direction of the study. Did the investigator start with exposure? Started with the exposure, followed and measured the few outcomes. That's a cohort study or prospective study. The word prospective is reserved for future outcome. The word prospective is reserved for future outcome. The word retrospective is reserved for past exposure, right? So exposure to outcome, that is cohort study. Now if you enroll based on outcome and measure the past exposure, that is your case control. Here your enrollment criteria is based on the outcome and you are measuring past exposure at the same time, right? At the same time, that is case control. Then analytic cross section would be where neither the exposure nor the outcome is the criteria of enrollment of participant in the study. That is analytic cross sectional study. If there is no comparison group, then it is descriptive cross sectional. At descriptive study, it could be cross sectional, it could be cohort. If I want to know what is the prevalence of a condition, cross sectional. If I want to know out of 1000, if I follow them for 2 years, how many of them they develop something that is incidence, it's a descriptive, right? So whenever I am not comparing, as you said, that is descriptive. Now you take one question. Same question you can answer using any of the 4 study design. And then you see what happens. Now let us take question, say for example, smoking and hypertension. I want to know, is there any relationship between smoking and hypertension or not? And if I ask you to design a cohort study, then what will you do? You will take smokers, you will take non-smokers. None of them are hypertensive, that's exclusion. You follow them forward and compare the incidence of, right, risk of hypertension in this, risk of hypertension and risk ratio or whatever, right? That's a cohort study, right? Same question, suppose if you have to do case control study, then you will enroll based on hypertension, no hypertension, and you will find out what is the prevalence of smoking in this, what is the prevalence of smoking in this, and then you compare. That is case control, right? What about analytic cross-sectional? You will have two cross-sectional, one smoker, other non-smoker, and what is the prevalence of hypertension? And then compare the prevalence. That is analytic cross-sectional. Now I want to do clinical trial to answer this question. Now I cannot take all individuals randomized into two groups, and one you smoke, one you don't smoke. That is unethical, right? So then I will take all smokers and hypertensive, divide them into two groups. One, let's say usual counseling, other one is intense smoking cessation. And then I see the effect on hypertension, right? If the drugs are coming down, I will say there is a relationship. So same question you can answer any of the study design. Now which design is better depends on the quality of data. And also you have to apply the Hills criteria, right? See, in randomized control trial, everything is like the kind of data that you generate in lab, where you can control so many things, right? Case control, you are measuring both at the same time. You don't know whether smoking, is it that those who develop hypertension, they started smoking or vice versa? I mean, right? So quality of data. So same thing again in one more way. Ask three questions. First is, what was the status of exposure and outcome variable at enrollment in the study? What was the criteria of enrollment of study? If it is based neither on exposure nor on outcome, it is analytic cross-sectional. But you will say, but we have inclusion, exclusion. That is only to define your target population. That is only to define your target population from where you will draw the sample. That is analytic cross-sectional based on exposure, right? So that is prospective. That is prospective. Based on outcome, that is case control. So if it is based on exposure, then you have to figure out was there an assignment or not. If yes, then clinical trial. If no, then cohort study. So that is how you figure out what is the study design. So when you write your proposal, right, and so there will be questions, there will be study design also. People make mistake. Recently, even for one of the intermediate grants, it was cross-sectional and they said cohort study. So many times things slip, so be careful. Because accordingly you will develop the protocol. As Dr. Pratap said, that go to Equator and look at those guidelines. Those guidelines are for submitting manuscript. But as he said, everything before the results section, you have to put it in your proposal, otherwise you won't be able to put it in the manuscript. You can't borrow from others' study. So use the same guideline, and everything prior to results section should be part of your protocol. Because at some stage you have to, right? So accordingly you will choose that guideline. I think this is all same thing in different way, multiple ways, at least one you understand, right? So here, see, cross-sectional, at the entry point, both outcome and exposure are there, and still time point. Many times people say cross-sectional is prospective study because my duration of study is 1 year. That's not prospective. Prospective means, are you following the participant or not? Right? In this you are not following, because you can't enroll 500 participants on one day. Right? So duration of enrollment should not become prospective study. Prospective is reserved for future outcomes. Okay, so here case control at the entry point, outcome is, because outcome is the criteria of enrollment. When outcome is there, exposure would have happened. So both outcome and exposure are there in case control. In cohort, no, and only difference is, so you see there are 4 study designs, method of analysis only 2. Why? Because look at the first 2. In first 2, cross-sectional and case control, both outcome and exposure are there at entry point. In prospective studies, cohort and clinical trial, exposure is, you are starting with exposure, outcome will happen subsequently, only difference is assignment. So there is one method of analysis for cohort and clinical trial, and there is one method of analysis for cross-sectional and case control. So designs are 4, method of analysis only 2. Things are very simple, variables are only 3, no 4th. Very simple. 4th, anyway. Now, observational studies, you will have real population. Which are the observational? Cross-sectional, case control, cohort. You have a real population means living in a fixed geographical area and take a sample from that, random sample. But in a clinical trial, no. You are sitting in the hospital, list of inclusion and exclusion criteria, and you enroll patients. So all those patients who are enrolled, they are not representative of all such patients in the population. That's a sample of convenience. This is a random sample, that is a sample of convenience, right? But results of all studies have to be generalized to some target population. For observational, it is real population. And for clinical trial, the population is hypothetical. And that hypothetical population does not belong to a particular geographical region. Hypothetical population will have members who have same characteristics as inclusion and exclusion criteria. Same characteristics as inclusion and exclusion. If you have excluded males, then your hypothetical population will not have female. We will not have males, right? So that is living wherever. If you have included stage 2 patients, then only stage 2 patients will be there, right? So that is what is basically, so this is sample of convenience, but all statistical methods, assumption is your sample has to be random sample. That is why they say randomization has to be there. That is why they say randomization has to be there. So that gives you green signal to use all those methods. Now, how many research questions are there in health sciences? Finite or infinite? How many research questions are there in health sciences? There are various levels of researcher. PG student hai, faculty hai, very senior researcher, so many disciplines. How many research questions? Finite or infinite? Infinite? No, finite. Is it in double digit or single digit? It's in single digit. There are only, I have not come across outside this. If you have come across, please add this and let me know also, I will also add. There are only 9 research questions in health sciences at any level. Only 9. 10th to hai hi nahi. Your words may be different, but it has to fit into my 9. So I would say 95% of the research questions, just to be on the safer side, they are out of this 9. So 9 research questions, 4 study designs, and 3 variables, and 2 method of analysis. That is all his whole entire research, right? So what are the 9 research questions? Read these 9 questions. Prevalence of a condition, very common. Second is mean of characteristics. Third is correlation. Fourth is agreement. Fifth is your diagnostic test. So these slides will be there. See, these slides I have already downloaded, so it will be shared with you, right? So first prevalence, mean, correlation, agreement, diagnostic test. If you have these questions, cross-sectional study. If your question is incidence, predictor, cohort study. If I want to know that because of my lecture, how many of you go to sleep? So during that 1 hour, that's a prospective study, that is incidence, right? But then not everybody slept. So how those who slept are different than those who did not sleep. Then I will see that those who slept, they also had dessert 2 times. Kheer bhi khaya, ice cream bhi khaya. So I can identify the factors, right? That's cohort study, analytic cohort study, right? Isn't it? So that is cohort, case control. Case control is poor man's cohort study. Poor man's cohort study. You can't do cohort study all the time because outcomes are not very common. It may not happen overnight or in a couple of months' time. So that is poor man's cohort study, also known as TROHOC study, cohort ka ulta. Cohort ka TROHOC study, that is case control. And last one is your intervention. Intervention studies, there are multiple variations, at least 36 you will see. There are 36, so many variations, right? So these are only 9 questions. You all have published papers, you all have done projects. Think of your question, it has to fit into this. It has to fit into this. If not, then you think of adding. There are only 9 research questions, no 10th research question. I have not come across 10th research question. cross-sectional cohort, case control, clinical trial. Now let us take each design one by one. So cross-sectional studies are basically one-time contact. One-time contact with the participant, you measure whatever you have to measure and thank you very much, right? So that is basically cross-sectional study. What are there are advantages and disadvantages. Advantages are you can study several outcomes, right? Like if I do a cross-sectional study, I can find out how many of you are sleeping, how many of you have a headache, how many of you are irritated. So several outcomes I can study, right? So that is cross-sectional study. Control over selection of subject. Then I can select subject that I will take only males I will take, females I will not take. I can be selective. I can select this one. Relatively short duration because one-time contact, thank you very much. Then good first step for cohort study. You generate hypothesis. Every study will have primary objective and secondary objective. Any proposal, if I don't see into primary and secondary, I immediately put it in a very low category. I immediately put it in a very low category, right? So as a part of secondary objective, you have to generate hypothesis, which you can test later with your analytic study. It yields prevalence because it is not meant to measure incidence. Disadvantages does not establish sequence of, because it is not meant to do so. You are measuring both outcome and exposure at the same time, right? It is not meant to do that. Potential bias in measuring exposure, because you are measuring exposure and outcome at the same time. So there is bias. Potential selection bias or survivor bias. You are taking only from those who are available to you. Those who are not available, they may be different than those who are available. So there is selection bias. Not feasible for rare condition. Does not yield incidence or true risk. Next is case control. In case control, you enroll based on the outcome, cases and control. What is the meaning of control? What is the meaning? Controls are most difficult to enroll in case control study. Controls are the one who had all the opportunity to become the cases but could not become case. They are the ideal controls, right? So you measure case, enroll based on case and control, and you can, what is advantage? You can measure several potential risk factors. Several potential risk factors you can measure, and then you can do the analysis. So that is advantage. This is done for rare conditions. If you want to find out predictors of cancer, then you can't do a cohort study because it will take, you have to start with huge numbers so that you get at least few, and that too after long years of follow-up. So in such conditions you can't do cohort study, so you have to do case control study. Relatively inexpensive, smaller sample size needed. Okay. Disadvantages, it is limited to one outcome because that is what is your enrollment criteria. You are enrolling based on the outcome, so limited to one outcome, right? If you want to know risk factors for hypertension, then you can't talk about risk factors for diabetes because your criteria of enrollment is based on this one. Potential bias in measuring exposure. Now look at this. In the population, you have these many cases, upper box, that many cases you have. Now out of that, many of them are seen elsewhere. This is hospital-based case control. Then you are left with, whatever you are left with, many of them are undiagnosed or misdiagnosed, right? Whatever is left with, many of them are dead or remission before the diagnosis. So what is available to you is very thin line. And based on this, you are generalizing about the entire population. So there is a bias, right? So hospital-based case control studies, which are mostly done, they have a lot of bias. Then comes your prospective cohort study. Prospective cohort study, right? Cohort is group of individuals, isn't it? There is a Roman, all that group of soldiers marching together in the battlefield, that is cohort. So prospective cohort. So once I say prospective, that means there would be retrospective also, right? So what is prospective cohort? You start with exposure and measure future outcomes. Look at that, there are a lot of variations in this. So look at this here, you are here now. If you start from there and follow these participants to look for the occurrence of outcome, that is prospective cohort study, right? Second one you see, that is retrospective cohort study. What is retrospective cohort? Suppose I did a cohort study, prospective cohort study from 2015 to 2020. 5 years I did a prospective cohort study. Today 25. Now my PhD student joins me. He comes up with a research question and he thinks that this question can be answered using my cohort data. So for him that would be retrospective cohort. Retrospective cohort is secondary data. Retrospective cohort is secondary. For me it was primary data, but for him it will be secondary data. It has advantages, it has disadvantages. Advantage is everything is ready. Data also is entered, right? Disadvantage is between then and now, a lot of things would have changed. And if my PhD student thinks about some variable which I did not think of, then he has to live with whatever I have. He has to live with whatever data I have. Methods of measurement may have changed. So a lot of disadvantage, but advantages also. That is retrospective cohort. Now next one is combination of the two, retrospective plus prospective. Suppose in your hospital some very rare surgery and one resident did surgery for let's say 2 years or 3 years and collected few cases. Now next resident comes and he continues. So for him that is, this part is prospective and piche ka that is retrospective. So both combined together is ambispective, provided things are exactly same in both part. Otherwise you can't combine the two. So that is ambispective, right? So these are variations in this. Advantages is, as I said, logical process of exposure to outcome, all that you can do. Disadvantage, not efficient as very large numbers will be needed, all that is fine. Nested case control study. Nested case control study is built within a cohort study. Like if I do a cohort study and I have a predefined outcome, but any other outcome that happens during the follow-up, I also record. And later some outcome which I had not actually predefined, I can consider as an outcome, as case, others says non-case, and look at the past exposure. Look at the past exposure which I have collected. That would be nested case control study. So quality of data in nested case control study would be better than usual case control study, because in usual case control study, data on past exposure is being told by the participant by recall. But in nested case control, I have measured exposure, right? So therefore the quality of data for nested case control study would be better. So analysis of nested case control, prospective cohort, retrospective cohort, ambispective study is done in one way. Now come to clinical trial. Clinical trial, there is a session on clinical trial, isn't it? There is a session tomorrow on clinical trial. So I'll not spend much time on this. Clinical trial, look at these words. Prospective, of course it is prospective. No clinical trial is retrospective, right? So whether you add the word prospective or don't add, it is understood it is prospective. Intervention, there has to be an intervention. To do clinical trial, you have to have an equipoise situation. You have to have equipoise situation and you should not be interfering with the policy. You should not be interfering with the policy and there should be equipoise situation, right? So can I do a clinical trial to test that how effective parachute is? So take 100 individuals on plane, 50 go with parachute, you push it, and 50 go without parachute, you push it. And see how many, and do that risk ratio and all that. Is it equipoise? No, you can't do clinical trial, right? Can you do a clinical trial to evaluate efficacy of some nutritional intervention during first 6 months of life of newborn? No, because that is policy is exclusive breastfeeding. Policy is exclusive breastfeeding. You can't interfere with the policy. You can do clinical trial to promote breastfeeding, maybe some education, so that intervention is allowed, right? But anything which interferes with the policy, you have to, so there has to be equipoise situation. You have to, there has to be something which is, okay, so look at this. What are the advantages? Advantages same as your cohort study, but additional advantages is you are allocating the intervention. So all of these are there. Disadvantages may be expensive in terms of time, money and people, all that is fine. I was telling you there are 36 variations of clinical trial, at least there are so many of them. You just look at these five terms. Your trial can be parallel, can be crossover. Parallel means allocated to one arm, remains in that arm till end. AB means AB, that is parallel. Crossover means every participant will receive both A and B in a sequence. So first participant AB, that means A first, crossover to B later. Second is B first, crossover to A later. That is crossover. So your trial can be parallel, can be crossover. Now in each of the two, your unit of randomization could be individual or cluster. So 2 into 2, 4. Now in each of these 4, your effect could be either superiority or equivalence or non-inferiority. So these are the criteria based on which you prefer one intervention over the other. So 4 into 3, 12. And in each of the 12, your outcome variable could be either categorical or quantitative or time to event. So 12 into 3, 36. So these are 36 minimum. There are a whole lot of other variations. So when you go to sample size calculation, you have to see what ये 36 में से कौन सा variation है. So there will be some slight changes in each of these variations, right? Core will remain the same, but there will be some change. For example, cluster randomized trial, your formula would remain same, but there will be something more attached to it, some multiplier, right? So you have to see all of these. Parallel is this, okay? Eligible subjects, randomized method. There are several methods of randomization. All that will be discussed later. So crossover, then you have incomplete crossover. Now come to sample size. Sorry, I've taken more time than what I thought I'll take. Come to sample size. So in this, what I would expect you not to actually calculate sample size, but if you can understand that for my question, what inputs are required for sample size calculation. If you can just remember that if this is my question, so to calculate sample size or to determine sample size, what inputs are required, that is more than enough, right? So for each of the question, I have 3 slides. First slide will tell you, say for example, prevalence. So what is prevalence of a condition? So 3 slides. First slide is what is that formula to calculate sample size. Second slide is an example. If my question is to know the prevalence of this, so for this, using the formula, how did I calculate? Third slide is, suppose I don't like calculation. There are ready-made tables available. So for the same thing, look at the table. You don't need to calculate. There is one more option, programs are available. But whether you use formula or look at the table or go to the program, you need to know what inputs are required. You can't, inputs that you have to, that nobody is going to tell you, right? So just remember that. So slides are there. I will not go through all the calculations, just go through that. If you read, I can tell you, there will not be anyone who will not understand. But if you don't read, I can guarantee you will not understand. So you have to read it. Now see, this is population, a sample, you saw this. So what should be my sample size? Adequate sample size. With large sample size, as Dr. Pratap said, you can prove anything significant. Anything you can prove significant with large numbers. With small numbers, so both are problems. Large numbers are problems, small numbers are problem. Small numbers, you will miss the effect. You will not be able to identify. Small numbers means आपके आँख का पावर ही कम है, तो आपको बड़े बड़े जो चीज़ें दिखेंगी, छोटी चीज़ नहीं दिखेंगी, है ना? So let us come to this. Now, whatever is your question, whatever your study design, at the end of study, we provide answer to your question. We provide answer to our question, and for every answer that we report, 2 questions will be asked, or you have to prepare yourself to defend from these 2 questions. How valid your results are and how reproducible your results are. How valid your results are and how reproducible your results are. And your protocol is basically to defend these. So any aspect which threatens validity and reliability of your study results, if that is not there in the protocol, incomplete protocol. What is priority in research? Validity or reliability or reproducibility? What is priority in research? You would like to have valid result or reliable result, or both, or none? Validity is the priority. Are you measuring what you're supposed to measure? Reliability is reproducibility. Are you measuring, are you consistent in measuring? Validity is the priority. Validity is the function of conduct of study. If your selection criteria is faulty, bias, it will not give valid result. If your measurement is wrong, it will not give you valid result. If your method of analysis is incorrect, it will not give you valid result. Right? Suppose my population size is 10,000. I say forget about sample size. I will study entire 10,000 population in wrong manner. I get wrong result, not valid. But the same 10,000 population, if I study 100 times in same wrong manner, I get same wrong result, absolutely reproducible. Would you like that kind of result? Reliability के लिए sample size है. By increasing your sample size, you cannot make your results more valid, which is the priority. So sample size means reproducibility. Look at the sample size, pay attention to your adequate sample size. So what we are going to see now, it will have implication on sample size, right? And to some extent it may also have on valid, because if you take too big sample size, there is inverse relationship between volume of data and quality of data. There is inverse relationship between volume of data and quality of data. I have not seen any study so far in last 40 years where any investigator who has collected all the data has actually analyzed it. So why you collect it? Nothing comes free. You are here, you are paying price. Even though your TAD, all that is covered, but you are paying price, right? At your workplace, right? Cardiac surgeon, you are paying price, right? So nothing comes free, right? So collect data only that is required. So in any study, please prepare your dummy tables first. And to fill those dummy tables, whatever questions are required, only that data you should collect. Besides some of the identifiers and all that. Anyway, so sample size. Now let us go. So there are 2 kinds of studies, qualitative and quantitative. Qualitative studies, there is no formal way of calculating sample size. So they have that saturation kind of thing. So they go on asking respondents, and there will be a time beyond which they don't get any new information. So they say that is saturation point, because they are not getting any variability. So that becomes their sample size. So there is no formal way of calculating sample size. In quantitative studies, there is formal way, right? So we'll discuss on quantitative. Again, in quantitative, there are two kinds of studies. One exploratory, second is confirmatory. Exploratory studies are those which are being done for the first time. You have absolutely no idea about what kind of results you are going to get, right? And confirmatory results are that if somebody has done some exploratory study or has done some confirmatory study, and part of the study has generated some hypothesis. So you can use that as a exploratory part, right? And that you can use for your sample size calculation. So for sample size calculation, you need to have a prior result, right? Some limited data, limited evidence you need to have. Now some people come to me for sample size calculation. So he came and says, this is my study, I want to know prevalence of a condition. So then I ask him that I need some results. So can you tell me what prevalence you are going to get? He said, this is stupid question, that's what I want to know. So then I said, can you give me some guess estimate? He had not done his homework and he said, nothing is available. So I say, you go back and do some pilot study. So next day he comes and says, sir, there are 5 studies available, but the prevalence is ranging from 20% to 50%. So I will take 20%. Rarer the outcome, larger will be the sample size. Rarer the outcome, larger will be the sample size. So I don't want to make mistake on sample size on the lower side. Larger one will give me better precision, right? So that is what I will use for my sample size calculation. Sample size will be an issue at 2 stages. One at the design stage, second at the interpretation stage. If you are reading somebody's result, then to know is it coming from adequate or inadequate or too large or too small, so it will be at that stage. Most studies, they don't do formal sample size calculations. They enroll participants based on their convenience or constraint. No, I have only 2 kids. 2 kids mein 80 hoga, 40. So my sample size is 80. Or I have only 1 year enrollment period, and whatever I get in 1 year, that is my sample size. So sample size is not based on your convenience or constraint. For sample size calculation, for a given situation, there is a formula. This formula is reverse of the formula that you are going to use for data analysis. Same formula that you are going to use for data analysis, only thing it has been rearranged and simplified. Rearranged and simplified, same formula, right? So at the stage of analysis, in that formula, everything is known. Sample size is known, results are known, right? So I do the calculation. But at the stage of sample size calculation, I want to know sample size based on the expected results. So formula is same, rearranged and approximated. People don't do sample size calculation, so often they take a small sample size. And because of small sample size, they are not able to identify the effect. They miss the effect. Suppose you are doing a clinical trial, A versus B. Your hypothesis was A is better than B. Sample size was small. You could not detect it. And then you say, there is no difference in A and B. Absence of proof is not proof of absence. If you have not been able to identify, it does not mean it's not there. आपके आँखों का power कम है, and a small particle you say you missed it. It does not mean it's not there. You did not have adequate power to detect that small sample size, right? So that is what is basically, but people what they do is, they don't do calculation, say this is a pilot study. This is misuse of the word pilot study. There is nothing like pilot study. Pilot studies are feasibility studies. It is, if you have to perform a drama, then you do rehearsal. That is pilot study, so that during rehearsal you correct your timings, dialogue delivery, everything. You don't mess up in your main play. That is pilot study. Pilot studies, you are not supposed to draw conclusion about your research question. Those are feasibility studies. But you just, people write pilot study so that question on sample size is taken care of. So that is misuse of the pilot study. N too large, already explained. With large numbers you can show anything. But is it meaningful or not? So if you use NFHS data, thousands mein hai. Even odds ratio 1.1 will be highly significant. Kya matlab iska? Right? So large numbers will have their own problems. There are 2 approaches, precision based, hypothesis based. Chalo, I think I'll skip all of this. For sample size calculation, these things are requirements. You must know variables. Variables are only 3 from measurement point of view. From measurement point of view, only 3: categorical, quantitative, and time to event. Time to event is combination of the 2. Time to event is when you assign importance to the time at which event occurs, that is time to event. For example, there are 2 deaths. One death occurs at 6 months and other one occurs at 2 years. So, and if you take categorical, both are deaths. But death at 6 months and death at 2 years, they are not same deaths. That is time to event. Cure at 6 months and cure at 1 year, they are not same cure. right? So when you assign importance, so that is third outcome. That is time to event, which will be in follow-up studies. It could be in cohort, it could be in study designs that you already know, summary measure, because sample size calculation is reverse of data analysis, right? So if it is prevalence, you should know what is prevalence. If it is incidence, you should know what is incidence, right? Third, then statistical errors, type 1 error, type 2 error, and something about normal distribution. Sample size calculation is not a rule. If you have calculated your sample size and given in a proposal, that is not a rule, it is only a guideline. If you said I will enroll 100 participants and if you are able to enroll 95, it does not mean gadbad ho gaya. And also you are supposed to enroll 100, but you went on to enroll 110, even that 110 could be less than what is actually required because prevalence is lower than what you anticipated. So any study you take, whatever outcome that you consider in sample size calculation, you will always get less than what you anticipate. We always get less than what we anticipate, right? So most people, when they calculate the sample size, what they do is they take some previous study, uska estimate le liya. No, uske estimate ka lower limit of confidence interval lijiye, because that also is a possibility. Rarer the outcome, larger will be the sample size. Right? Uska lower limit ko pakadiye, usko use kariye, sample size calculate kariye, right? Because sample size formula is approximate, these are guesses, results are guesses, and coming from prior small studies. So how can it be a rule? It is only a guideline. There are three ways I told you: formula, ready-made table, software, right? Now there are inputs required for sample size calculation: anticipated outcome, hypothesized value, alpha, beta, power, sampling design, method of randomization, modified alpha value due to multiplicity. If you have two primary objectives, your alpha value will not be 0.05 for both. Your 0.05 is assigned for one study. So if you have two, split. If you are doing a clinical trial, doing interim analysis, split. Yesterday I was in some meeting, two primary objectives, and they are doing two interim analysis. So just imagine what will happen to alpha value. Same 0.05 has to be shared, and even your sample size calculation has to be done accordingly. Sample size calculation, because at the end you will not be left with 0.05 because you have already spent some alpha. So all that you have to take care of. Now look, please pay attention to this, and we can stop here. Suppose your objective is first one. What analysis you are going to do? There is a session on analysis, but what are you going to do? Prevalence of a condition, so you are going to calculate prevalence. You are going to calculate prevalence, and then you are going to calculate range of results, 95% CI. See, no one is interested in knowing what you got in your study. No one is interested in knowing what you got in one study. One is always interested in knowing range of results, because he also does not know what is the true result in the population. So for prevalence, you will report 95% confidence interval, right? So for calculation, anticipated prevalence and half of the width of the confidence interval, which is D, and then you say 4 PQ upon D square. So that will be input for sample size calculation, right? D is precision. Sample size is like shopping. Sample size is like shopping. Most investigators will have constraints. So if I have to go and buy some shirt, so even though I have enough money in my account and all that, but mentally I know this is my limit, I can't buy more than this, right? So then I maximize. I go to different shops and maximize. So when you do sample size calculation, calculate for multiple situations and settle for the one which has two criteria: feasible for the investigator and technically acceptable. Settle for that number. but you do multiple sample size calculations. So second one, mean of the characteristics. What are you going to calculate? Mean, standard deviation and 95% CI, that will be the input. For third one, what are you going to calculate? Correlation coefficient and 95% CI, so that will be the input, right? Agreement, what are you going to calculate? Some measure of agreement. If both are categorical, then if categorical, you will calculate kappa statistic. If you are quantitative, you will use the Bland, Altman and all that, right? Diagnostic test, what are you going to calculate? Sensitivity, specificity as the characteristics. And for sensitivity, specificity, 95% CI. So like two prevalences. So that will be the input for sample size calculation. If you are going to use incidence, anticipated incidence, and half of the width of the confidence interval. If you are going to use predictor, that is your question, predictor of an outcome, then what are you going to calculate? You are going to have a 2 by 2 table. You are going to have 2 by 2 table, and from that 2 by 2 table, you will have risk in 1, risk in 2, and the ratio of the 2. So three things: risk in exposed, risk in unexposed, and ratio of the 2. So of the 3, if you know any 2, third one you can calculate. So that will be the input for sample size calculation. Case control study, if you have 5 potential risk factors, then do the sample size calculation for all of these 5, or do for the one where prevalence is least. That will give you largest sample size, which will be more than adequate for other 4, which are more prevalent than this. Clinical trial, then find out what is your effect size, what is outcome rate in 1, outcome rate in 2, and alpha beta. So these are the inputs for sample size calculation. And hereafter see, but one request is, please write your objective as primary objective and secondary objective. Sample size is calculated for every primary objective. If you write your objective as 1, 2, 3, 4, 5, I will take all of them as primary. So divide, but you say all objectives are important for me, do for all. Whatever is feasible, draw a line. That becomes your primary objective, others are your secondary objective. 95% of people don't know how to write objectives. When we read the proposal, to study, to see, to appreciate, to observe, to measure, these are activities, these are not objectives. Use action words. Use action words. So the way you write your objective, that person can see who you are without seeing you, right? So rest of the things he will read accordingly. So write your objectives properly. Many times we see clinical trial, so 3 objectives. First objective is to about the outcome 1 in group 1, outcome in group 1, second is outcome in group 2, third is comparison of the 2. So it should be non-overlapping. Write in PICOT format. Write in PICOT format. Even if your study is observational, you will not have intervention, but you will have exposure, right? So it becomes PE, not I, E, and so on, right? So whatever is applicable, so in cross-sectional, everything will not be applicable, but whatever is applicable, you must write in your objective, right? So please write your objectives properly. Write your research hypothesis properly. Null hypothesis, alternate hypothesis is not your hypothesis. Your hypothesis is research hypothesis. Null hypothesis, alternate hypothesis is the statistician's hypothesis. You had research hypothesis, which is unit is what you're sampling. So sampling frame is total, variable, okay, all that is fine. There will be 2 kinds of error. One is sampling error, other one is non-sampling error. So any error which you can attribute to the sampling error, and all other errors, measurement or analysis, they are all non-sampling errors. There are 2 kinds of sampling, probability and non-probability. Always we encourage to go for probability sampling. In probability sampling, every participant has known probability of being included in the sample. That is what is probability sampling. There are various sampling methods. What is random sampling? Each subject has known probability of being chosen, all that is fine. These are commonly used sampling methods: simple random sampling, stratified random sampling, systematic random sampling, cluster random sampling, multi-stage sampling. Simple random sampling means, for simple random sampling, I need to know the frame. Suppose out of the participants, if I have to select 10 participants randomly, then I must have a list of all the participants, 1, 2, 3, 4, and 39, right? And out of this 39, I should select 10. So that means I know who is number 5, who is number, so sampling frame should be there. This is the best sampling procedure, but this is theoretical, not possible to apply in field conditions. We don't have frame, right? But if possible, you should use sampling. If frame is already available, then this sampling is a better method. Stratified random sampling is where your population is not homogeneous. Population is not homogeneous, then you divide into strata, and from each strata you take sample, and that all the sub-samples becomes your sample. So this sample is more representative of the heterogeneous population. Like your population has rural, urban, so take from rural in the same proportion as take from urban, so your sample, this is hopefully representative of the population. So that is stratified. So you need to know the characteristics of the population, right? Systematic random sampling. Suppose I have 100 numbers, I need to select 10. So I'll divide into 10 blocks. First block of 10, second block of 10, 10th block of 10. And in first block, I will select one randomly. Suppose one randomly selected is number 7. So once this one is selected randomly, rest all are automatically selected. So 7 plus 10, 17, plus 10, 27, plus 10, 37, and so on. That is basically systematic random sampling. Cluster random sampling is, suppose you are doing some population-based studies. You have villages. Now you want to select few villages. So villages become the cluster. The difference between cluster and strata is, cluster is naturally existing. The strata we are making. Like I can make one strata of large size villages, second of medium size villages, third small size villages, that I have made, right? But strata could be, strata is a strata I am making, cluster is naturally existing, and then I select few clusters. So I don't need to know the detail of those clusters which are not selected, right? But usually in population-based studies, you will use multi-stage sampling. So at first stage, you may use, so let's say, convenience also. Suppose you are doing population-based survey, so you may, out of so many districts, you may select one district based on your convenience, because you think that is feasible for you and that is approachable or whatever, right? And then later, so we use combination of these, non-probabilistic, probabilistic. So all of these are there. So I'll stop here. So this is basic, that example, 50, let's say 50 students, I need to select 10, right? Then use random number table. So I need to have the frame 1 to 50. Go to random number table, select one number randomly. 50 means 2 digits. So pay attention to last 2 digits of every number. So select one number randomly. Suppose that is 32063. So I look at last two digit, 63. So forget about 63 because our maximum is 50. And decide you want to move row wise or column wise. Suppose I move column wise. So 63, forget it. 56, no. So 31, yes. So 31 is the first one selected. Go next. After 31, 0, 0, no. Then 31 again, I can select same individual 2 times. Forget it. Go to next 81, no. 30, yes. Then 1, yes. 13, yes. So like this, then again move top, and that is what is your random number table. So you can use your random number table. So I'll stop here. I know. If there are questions, I can take questions. Yeah. These slides are there. Please go through the slides.
Thanks a lot, sir. Sir, in the analytical cross-sectional study, so we are measuring prevalence, but prevalence is descriptive.
Prevalence is?
Descriptive. Descriptive. Descriptive, sir.
Prevalence is descriptive, but we are comparing two prevalences.
Okay.
So analytic cross-sectional is nothing but two cross-sectional. Analytic cross-sectional is nothing but two cross-sectional studies, and we are comparing the prevalence. So like, let's say, smoking and hypertension. So my one group is smoking and hypertension. So this is one prevalence study. What is the prevalence of hypertension among smokers? Second is, what is the prevalence of hypertension among non-smokers?
Okay.
From the same population, right? And then I'm comparing this prevalence of hypertension. That is an analytic cross-sectional.
So the sample size, like when we are...
sample size would be based on
prevalence,
yeah. Prevalence in one, prevalence in the other one. And there will be all the sample size calculation formula, there will be two kinds of ingredients. One that will come from the investigator, second that will be statistical. So statistical is alpha and power. Alpha and power
is not needed for descriptive.
But this is not descriptive.
So when we put it, so
yeah,
we have to
if you're doing single prevalence, power is not needed. If you're doing diagnostic test study, power is not needed. Because again, diagnostic test study is again two prevalences. Diagnostic test study is nothing but two prevalences. Prevalence of test positive among disease and prevalence of test negative among non-disease. So these are two prevalences. But there you are not comparing sensitivity and specificity. So therefore not analytic. Right? Diagnostic test would become analytic when you have one reference gold standard, one index test, and another comparator. So index test versus gold standard sensitivity specificity, comparator versus gold standard sensitivity specificity, and you compare two sensitivity and two specific, then it will be analytic.
Okay, thanks.
Excuse me, sir. Sir, I had a question, sir. You mentioned about multi-stage sampling. So in sample size calculation, while carrying out multi-stage sampling, there is a term that we encounter which is known as a design effect.
Yes, yes,
if
because in multi-stage sampling, in multi-stage sampling, you will be using cluster random sampling. Some cluster will come somewhere, right? So once cluster comes, isn't it? Then you have to use design effect. Multiply by, let's say, 1.5 to 2. Why do you multiply? Because if there is a cluster, that means homogeneous. Homogeneous means variability will be less. Variability is less means standard deviation less. Standard deviation less means standard error less. Standard error less means your confidence interval will be precise. That is false precision. So correct for it, you...
Sir, are there any rules of thumb by which we select the design effect? You mentioned 1.5 or 2.
Usually 1.5 to 2 people take, but again at the end of study you should calculate and see what did you get. Yeah.
Thank you, sir.
Thank you so much, sir, for a very intriguing session. This is a very technical session, yet you have simplified enough in your explanation with simple and lively examples. And thank you for answering the question, sir. I'm sure by the nature of the subject and content, there will be lots more questions and doubts from the participants. So we would expect participants to raise more questions in the later on. If we cannot, if we do not have time to answer within this session also, like we will write to the resource person, which I'm sure they will be happy to answer. So before moving on to the next session, we would like to felicitate sir with a small gift as a token of love and appreciation. To do the honor, I would like to request Dr. S.A. Khan sir to kindly felicitate sir. Pandey sir, kindly come forward, and I request Khan sir to kindly hand over the small token of gift that we have. Thank you so much, sir. Now we would move to the next session, a session on new area of research, which is the implementation research. To take up this session, I would like to invite Dr. Vishwajit Kumar, sir, founder and chief scientist of the Community Empowerment Lab, Lucknow. Sir, kindly take the stage.
And this I do it. Perfect. Thank you. Well, thank you very much. Thank you, Professor Pratap, for when I heard your introduction with the word retire, I think teachers in our country, in our land, definitely never retire. And thank you for for a session complete full of wisdom. Thank you, dear friend and senior Dr. Sanjay Juvekar. Dr. Pandey, I've never seen him happier actually since Punjab Kings actually lost the T20. So he was rooting for that. I flew in from Bangalore. Bangalore won. Dr. Pandey was, but thanks to this amazing workshop, I've never seen him happier. So help him. So now he's happier. So I'm very pleased. So I know the next speaker is Dr. Sangamitra. She's a very eloquent, and I think that's something that each one of you are looking forward to. And therefore, I'll try my best to finish it on time so that she is able to start her session at 4. So, and before I begin, let me thank all of you here, all the organizers, and this wonderful land. Every time I come to the Northeast, I always feel so blessed that what a beautiful country that I've been born into. So thank you very much. Okay. So I just got a little more time, so you just have to bear with me a little longer, but I'll still try to be on time. Okay, great. So we are going to talk about, I'm just going to take you through implementation research. It's a field that's still young. It's a field that's not very well understood. A field that actually leaves you more confused than you started with. And I will try my best to leave you with a little more clarity than I started. And and for everything else, we have Dr. Prem and Dr. Sanjay. Okay. So, implementation research, particularly under the current leadership of ICMR, I think it has seen the much needed impetus. And I think it's also a moral imperative for the country. Over the past couple of years, there are many of you in the room who have been grantees of the implementation research grants by the ICMR. And that's one area that has seen the most emphasis and the most proliferation. And I'll try to make a case of why it's very important. If by the end of this session I can get you interested in implementation research to even at least attempt to start thinking about it, I think I would have succeeded. And I speak on behalf of both Dr. Prem and Dr. Sanjay and Dr. Pandey as well. It's probably, he's somebody, as a statistician, I think he has a much better conceptual clarity of implementation research than a lot of implementation researchers themselves. I have, my background has been, I'm a physician, but generally been a clinical trialist, conduct large complex trials, and implementation research is something that I believe it was very important. So I consider implementation research as the one that bridges the divide. And that divide is extremely important here. Today we heard about most of the work that we see, particularly even in a country like ours. We find that most of the work is within the discovery and the development phase. We know what works, But when we go down to the field for the last citizen that we want to serve, the last mother we want to serve, we don't see that in practice at all. We also see a huge gap between the evidence-informed policy and how it translates onto the ground. And therefore, a country like ours, we are aspirational, we are ambitious. And therefore, when we set goals based on what we know, I think implementation research makes the difference between our aspiration and the real impact that we see in the field. And therefore, I see this also not just as a methodological imperative, I see this also as a moral imperative for a country. Now, and this divide translates into real lives lost. These translates into lives of newborns. The area that I mainly work on, it translates into lives of mothers lost across our country. And just to give you one statistics, that 2/3 of newborn deaths can actually be averted with what we know. And yet, we have 2.3 million babies die every year, which is close to 8,000 every day. And most of them, they're not in the Western Hemisphere, they're not in the Northern Hemisphere, but they are in South Asia and Sub-Saharan Africa. So the price that we pay for this division is disproportionately higher for our citizens. And so if I were to project it now further and see what would our country look like by 2030, and this is for neonatal mortality, you see that this equity actually tends to sharpen. And therefore, I think it's important that this division just does not stay as we speak, but I think it gets amplified as we move into the future. And therefore, I think it's very important that we also need to look at and see what is the anatomy of this divide. And so one key division, one key layer, actually, if I were to peel it layer by layer, the first, of course, is the scientific divide. We have disproportionate investments made in the discovery side of things, in efficacy trials. We know what works within these elite laboratories across the world, but then it completely fails when we want to translate it. And therefore, even somebody like me have largely been doing these trials within these controlled settings in randomized controlled trials that have very limited application. And the moment we even attempt to try to put it in the system that we do not understand, it completely fails. And so we have very limited investment and understanding, both in terms of financial and intellectual, in terms of our understanding of the delivery system. And that's one part of the divide. The second, of course, is the political divide, is, you know, what actually needed, what is needed for us may not necessarily be informed based on evidence. And there is another reason, because when we fail to translate what we know into real impact in the field, which also means that our policymakers have less incentive to make those investments. So they'd be happier to make an investment on making roads rather than necessarily making hospitals. The third, of course, is structural divide. When we create these interventions in our nice, polished, controlled environment, we are completely negating researched, intensely researched topics, or if I may call interventions in my field. And it has, overall, it leads to a 40% reduction in neonatal mortality. Now, we know of no other interventions that has such an effect size. And thankfully now, just 2 years back, the World Health Organization updated its guidelines for low birth weight and premature baby, and this is the #1 recommendation. Now, but if we look at what it can actually achieve. If we are able to take it to 90% of our low birth weight babies across the world, we will be able to save 450,000 lives. That's how powerful it is, and yet less than a small minuscule percentage of our babies actually receive this life-saving intervention. They're not manufactured in pharmaceutical companies in the United States of America. This is not where some Western nations hold a patent. It is something that is absolutely accessible to the poorest woman on this planet, and yet we have not been able to take it to her. And so this was the goal that we had set ourselves, and I say we also includes the Director General of ICMR, Dr. Rajiv, Dr. Prem, and a whole host of other people. And the idea was, how do we take what we know and see and take it to where it matters within the existing context of our health system. And so what was missing is, of course, a scalable model that worked within the chaos of our own realities. And so this was the question that we are here for. So essentially we want to, but we don't know how. And so we went through a stepwise process, and I will try to take you through that. Of course, I have to confess that, retrospectively, everything appears very clean and very neat. Going forward, everything is messy. So this is being sanitized for you. So here, I will define what implementation research means for me. For me, it is the science of building bridges from barriers. So wherever we see that impossibility, that's where we see implementation research as the potential framework, methodology, and also more importantly, a mindset for us to overcome that. So if I were to be in Assam or in the northeast of our country or the country in general, and if we know that this is an intervention that should be to our baby, but we have failed to get it, I think that's where implementation research comes in, because we are like, these barriers, we will build bridges from here. We'll go now, and I'll start with this. So we framed everything just like any other clinical trials or we will frame this research question that Dr. Juvekar talked about. The difference here, unlike many of those clinical trials, it starts with a how. And so here the question that we had posed was, how can we co-develop and implement a delivery model that achieves 80% coverage and high quality, and I'll let you know in a moment, kangaroo mother care for stable newborns with birth weight less than 2,000 grams across the continuum of care within a district. So this is kangaroo mother care. One of the key prerequisites for an implementation research is that the intervention that you want to scale, intervention that you want to integrate, should actually be evidence-based, and possibly already we have a policy position on that. In the case of kangaroo mother care, this was already a global and a national policy. And we just wanted to make sure that within our existing health system, within our limitations, within our manpower constraints, within our bureaucratic realities, can we actually achieve 80% coverage, and high quality meant greater than 8 hours every day. And so the first step that I believe was very important is, and I would say if you have a research question for the country, for the state, then once you have done that, then my advice would be, the first step would be engage the ecosystem. This is very radically different from how you would be as a principal investigator if you were doing a clinical trial. Every study that I have done, I was the king. I never had any stakeholder to engage with. But when you are a principal investigator of an implementation research, you have the first and foremost. Implementation research requires a lot of humility. And therefore, it's very important that you engage the ecosystem. And that ecosystem is all of those who have a stake here. For example, in this case, it was the Minister of Health. It meant it was the Secretary of Health. It meant it was the is the mission director of National Health Mission. It meant the chief medical officer. It meant the pediatricians, the neonatologists, the doctors, the Indian Academy of Pediatrics, the National Neonatology Forum, and more importantly, the mother. Implementation research is a team sport. You might be able to get a grant, but you will never be able to translate into a scalable model until and unless you absolutely recognize and play it as a team sport. Deep relationships with stakeholders is the absolute foundation. We talk of systems, but systems in high context societies like ours, in India for example, it is ultimately relationships that matter. I was talking to Dr. Pandey and me, we were in Palghar as part of a study, and we were just talking that we have to come to Dibrugarh for this workshop. And one of the things that, and I said, how did you find time? Because I know you have a whole lot of other meetings. And he was like, they're just, everyone in Dibrugarh is so great, and Dr. Prasant is so nice. There's no way I could have said no. Relationships in our context is the king. Ultimately, it matters. When I was hearing in the morning Dr. Lakshmi Narayanan, he said, I came here, I started my career in the Northeast, I have a lot of soft corner for this, I'm retiring the next month. I wanted to make sure, and Northeast capacity building for Northeast is a priority for the country. I wanted to make whatever I can do to make this happen. Relationship is absolutely crucial. The second, I think for some of you who are from the government system, it is very important for the principal investigators who usually for clinical trials, you're the king, you hold the key. Here in this case, if you had a key, you need to hand over that key to the government or to whoever the key. In this case for our district, it had to be the chief medical officer. So the implementer, it is implementation to the power of research. The implementer has to be in the driver's seat. The researchers have to be the navigators of this. The next, and therefore, as you can see, a whole lot of logos only means that we had to build this entire ecology of partners and relationships around the mother and the baby. The second step is just understanding the problem. And I think it's very important. And here you need to put on your, just as you would want to diagnose a problem as a clinician. Here, it's just a little more complex, but the approach is the same. You do not treat symptoms, you do not design solutions for symptoms, but you want to go to the root cause and you want to go deeper so that you can address the problem itself. And this is very important. If any one of you who have done courses on implementation research, many of you are intimidated by the theoretical frameworks and models, and one of them is CFR, and you have at least 100. I would just say that those are just checklists that you can use, and I will not use it, but you will see how we have used it. So understanding the problem is very important. So let's say we have, what is the problem here? We have an evidence-based solution. We have all the countries, all the UN countries in the world, they have signed up a declaration that we will reach by 2030, I believe an 80% or a 90% coverage for all low birth weight babies. And yet we have abysmally low, less than 1% coverage. So we need to understand the problem first. Okay. So evidence does not mean impact. There are a whole lot of other things within it. So let's look at the intervention itself. The first and foremost, our biomedical community is actually used to procedures. They are not used to a complete natural, completely alien concept as kangaroo mother care. In our neonatal intensive care units, mothers are not part of the solution. They're actually seen as an interference. So therefore they are kept out, and out of the window they need to be looking at the baby if the baby is still breathing or not. Here you're saying, well, they need to actually come in and they have the ability to save the life of a baby. That's profound. That's not profound for every mother. She knows it, but it's profound for a pediatrician and a neonatologist. It's profound for the medical professionals. The other is, how do you convince somebody that the act of simply putting the mother, a baby to a mother, can reduce mortality by 40%? It's very hard for the way we have been medicalized to actually make sense of it. And therefore, one of the problems with kangaroo mother care is because it also appears so natural and therefore and invisible that it becomes very difficult for us to actually convert that into a procedure. We have other problems as well. In order for the baby to receive kangaroo mother care, where does she give? She comes into a facility, delivers, goes away within on an average time of 7 hours. That's too less for her. Besides, look at the picture here. When she is born, the baby is separated immediately, kept there. She comes to this postnatal care ward. It is not where she needs the privacy for her to be able to unclothe and put the baby on a skin to skin. The beds are not comfortable enough. She doesn't have those comfortable chairs. And of course, when she goes home, you can see the lack of resources. Above all of those, the lack of space, the lack of understanding, the lack of knowledge, the lack of awareness, the lack of skills, we can go on and on. So it's very important that we have to understand. For those, if you need a technical term for it, one approach that really helps is the CFR, is the Consolidated Framework for Implementation Research. What it does, it gives you a checklist of things that you can look from the intervention to the individual, to the facilities, to the outer setting, policy, etc., to actually study these barriers. What we found at the end of the day, that the entire focus was on kangaroo mother care, while actually the focus should have been on the mother, what we ended up designing. So this is a government, this is entirely funded by the National Health Mission and the government of UP. And so this is what we built. We said the mother should be the new VIP. In the changing times of India, the mother needs to be the new VIP. When we designed this, we wanted to make sure that it's not something that is just good for the mother, not just good for the baby, but it is good for every stakeholder. So we used a design principle known as value proposition design, essentially saying if this innovation does not help, if it does not bring value to the Minister of Health, it will not work. If it does not bring value to the Chief Medical Officer, it will not work. If it does not bring value to the mother, it will not work. So we created this respectful, dignified, air-conditioned, where she gets all the meals, etc. And the rest of the model is as following. So, it's, I think, just in the transmission, but, I'll be fine. So you have the lounge at this. The other is we created a cadre of KMC nurse coaches. They're all funded by the National Health Mission. We had counseling tools that were culturally aligned, and we had a data-driven to govern so that they could be. You have done this, then the next step 4 is we need to iterate. Unlike a trial, where any small changes in the protocol means that we have to go back and go back to the IRB, we need to file an amendment. Here in this case, iteration is absolutely core to this. This is very distinct from how I would have conducted a trial. So here, we go through a process of iteration, integration, and very important that the entire process needs to be documented. And so here I will not go into detail, but essentially it means that we moved from model 0 to model 1 to model 2, model 3. In our case, we started with the health facility, then we added the home piece, then we started the governing piece, and then we had data to guide the decision making. We're not blind to the data, but data was being used by the health system to refine and adapt. This is just one dashboard for the district to be able to see how they're performing across 11 or 12 parameters. And then the step 5 is evaluate. It is very important that we generate evidence. Here I will just pause that here in our case, we had a baseline and then we had, we followed these babies. That was our design, but we have another study, but you could use literally anything. You could use a step wedge. You could use just literally any design to evaluate it. And this is what we found. We found that yes, actually from less than 1%, you could actually achieve greater than 90% initiation of kangaroo mother care. You could achieve over 53% of them to actually provide greater than 8 hours KMC along with immediate exclusive breastfeeding. That you could achieve median of 15 hours within health facilities. We could also see that when they go home, they will continue to do that as well. More importantly, what we saw, compared to the SNCU, the Special Newborn Care Unit, where we had seen that you had more male babies compared to female newborns, here we found that both of them were similar. So this addresses the equity issues as well. And part of the reason is because when the mother immediately puts the baby on a skin to skin, she has this bonding, and all of those then changes her behavior going forward. This is just one example where we saw that the community health center performance was much better than the one at the district hospital. And it has other implications, and that has led to other modifications as well. The step 6 is the scale. Many of you will have a grant that will only allow you to build something for a block or probably for a district, but I think the real test of an implementation research is that it should continue to scale. And so as I speak, we have now moved from, from 6 or 7 that was part of the study. Today it is in 361 facilities across 4 states, actually UP, Haryana, Haryana just a couple of them, but Rajasthan and Andhra Pradesh, and it'll continue to spread. The last one I would just, this is probably my last slide, and this is, but we don't stop learning. Here it is very important that this is not a project that you do and you dust it off. I think it's important that we need to continue to evolve with it. One of the key evolution is that now we had a study again that was led by Dr. Rajiv, a multi-country study where all the work that of KMC that I talked of there for stable babies, they were physiologically stable babies. And there was another trial that he did where he actually found that unstable babies, if you initiate KMC in unstable babies, you could reduce neonatal mortality by 25% above those that you will achieve by stable babies. So this is one of the first SNCUs. These are level 2 neonatal intensive care units where we have the mother inside the baby, and she could be, so this is amongst the first in the country. And this is another implementation research we have begun. So we are hoping that as we move forward, we'll continue to take this to the rest of the country and the world. And I will just end this with that implementation research. I would urge that you go, when you go back, do strongly consider every time you see that we know what works, but when you go to your village, when you go to your communities and you see that it is not reaching them, that's a case for an implementation research. We have the good fortune, I think the country is making major investments, particularly the Indian Council of Medical Research, for this. And I can tell you about, Dr. Prem, Dr. Sanjay, Dr. Pandey, myself, we are available for you all the time to help you so that you can actually work on your proposal, and nothing would give us more pleasure than for you to get it funded by ICMR or any other institution for the citizens and people of the northeast of India. Thank you very much. I wasn't bad. So I've taken 8 minutes of the next one. Yes.
If there's any quick one or two questions, our resource person can answer. Any questions?
Okay. Good. Thank you. Yes, please.
It's actually not a question, it's an observation, because in Northeast India, you can see, and we have observed that in particularly women, when they are engaged in the plowing, in the agriculture, they hold their babies right in front and in back also. I feel that they have also some effects, and then the survival rate of the babies may be higher. I don't have any idea.
What is higher?
When the women, they goes for the plowing or the agriculture, they hold their babies, right? So maybe that have a positive effect. Yeah. So I don't have an idea, just I want to share.
No, that's absolutely possible. You know, we have many geographies within the country where this is the practice, and I think, unfortunately, and therefore I think it's very important that we need to look around within our own country, within our own communities, and there could be practices that, you know, needs to go out to the world. You know, one example, one area, the other area that I work in is emoliation, is massaging a newborn. You know, in Europe and the US, you know, children have traditionally never been massaged. And that practice also started. Within Asia, South Asia in particular, you've had, and India has a very deep, rich culture for it. Now we have increasing evidence that this could be very important, not just life-saving, but also in terms of neurodevelopment, et cetera, et cetera. So you know, these are absolutely areas for, you know, for us to interrogate that, right? Explore, develop the evidence, evaluate it, and take it across the country. So, okay. Okay, thank you very much.
Thank you so much, sir, for introducing to us implementation research, and that too through a very successful IR projects that you have carried out. Actually, sir, we at RMRC NE, we have just recently started one project on newborn care and neonatal mortality in Tripura. Just last month we have started this project, and just last week we were having one workshop on this project with Sanjay sir as the resource person. So I personally have so many questions, and I hope my colleagues also have some questions on this KMC. In the field, we have so many confusion, and we have so many questions regarding the KMC, which, sir, I will personally discuss with you later. Thank you so much, sir. We would like to hand over a small gift as a token love of our gratitude, sir. To do the honor, I would like to request Dr. Biswas Borkokti, sir, to kindly hand over the gift to our resource person. Thank you so much, sir. Now we will have a short tea break where tea will be served in the same area where we had the morning tea and lunch. And after that, we would be having a session on essentials of publishing research papers. I am very sorry to announce that the session on writing good proposal by Dr. Sangamitra ma'am, she is not able to make it today. So she will, if possible, she will try to take up tomorrow. Otherwise, this topic will be covered in the report writing session by Borkokoti sir tomorrow in his session. So before we break for tea, I would like to announce that the owner of this facility has came and apologized to us for the interruptions we had during the inauguration session. And because of that, he has especially arranged for us a live musical show after the session is over. So in between the session and the dinner also, we will all have together dinner here in the same place. So just before the dinner, we will have a live musical show just outside in the open air amphitheater. So I want to announce that. And further, just I would like to make another announcement that our account teams are here in the reception areas. So participants may kindly approach them for any reimbursement related queries. And even just now they're asking for the return boarding pass to be submitted. So kindly make sure to comply with the account formalities. Thank you all. We'll break for tea now, and then we'll come back in 15 minutes. By 4:30, we'll start the next session. Thank you all. Roy sir, Director of ICMR and ITM Belgavi. So I would like to invite Roy sir to kindly take his time. Sir, please, the stage is yours.
Good evening, everyone. Hello. Good evening. I know it is the last session today, and I think I will try my best not to bore you. Is it okay? Am I audible? I think it's okay now. Yeah. So what I will do is that I will try to present to you the essentials of publishing research papers. I will try to be as basic as possible, considering, say, if I were in your place, what I would rather do, and at the end I will try to give you some of the examples that we faced ourselves. Before I start, I bring to you greetings from my parent institute, the ICMR National Institute of Traditional Medicine, located in Belgavi, at the tri-junction of Karnataka, Maharashtra and Goa. So I will speak about the overview of the landscape of scientific publishing, the trends in the publishing what we see today, the preparations of writing a manuscript. I will skip because Dr. Panda is there, so he will be speaking about that. Even submission process also I will skip a little bit. Some of the present challenges with some examples. Again, ethics I will skip because I think Dr. Saurav will be speaking to you tomorrow. But it is part of the entire process. So somewhere you will find repetitions. And of course, with the first presentation which Professor Tharian has given to you, you are all very much aware of the issues that happen particularly with clinical research, but keeping in view that there are quite a number of basic research scientists and preclinical research scientists as well. So I would try to generalize things as much as possible. So we know that scientific and academic publishing actually describes articles that are distributed in academic and research scholarships, mostly done in journals, books, and theses. And it is not the formally published, but the mere printed up or posted materials we call as gray literature. Most of the scientific and scholarly journals and books are based on some kind of a peer review, some kind of scrutiny that takes place before they are published. And this quality of review again is subject to various standards, and they vary greatly from journal to journal and from publisher to publisher and field to field. Now, why do we publish? Why do we normally publish in the first place? That is the currency of a scientific organization or an university or a research institute or even a scientist. To register a discovery made by us on a certain date. So it is the priority, as we know, who was the first, sometimes for IPR registration. To get the quality of the research and by implication the scientists themselves stamped by an authority of publication in a journal of known quality. So what we say is that we are known by what we publish. To get our peers also know what we have done, to attract recognition, promotion, appointments, reward, collaborations, and of course, to leave a permanent record of research of lasting recognition and immortality. I always tell my students, perhaps we are blessed as researchers because we plan what we want to do. we design our study, even we design who are the people with whom we are going to work with, our collaborators, our project staff, and who gives the money for it? Mostly the funding agencies, the government, even perhaps most of the time, for most of us, I think the salaries come from the government. And when we publish them in our names. So, and whenever we leave that job and go to somewhere else, as a tail we carry all the publications that we do, which does not happen in other fields. And when we die, if our work is good, our names, our papers will be quoted, if that is a good work. So perhaps no other profession has got this kind of advantages or this kind of perks that we as researchers enjoy. There are other reasons as well to get monetary benefit, 0.6, India around 2%. So these are the countries by the number of scientific journals published as reported by Scopus during that time. And you can see here, United States was leading, and India was at the 13th position. And China was quite ahead of us. We look at the countries by citable number of documents. Here again, we see the same countries like US, Japan, United Kingdom, Germany, France. So they were the leaders. India was also almost at the same level. Now the countries by number of sites per document. So if we look at quality, and if the number of sites per document is an indicator, then actually we will find some countries which are not expected, but they stand much ahead of even those developed countries that had the more number of publications. For example, USA was on the 21st place, UK was 38, India was 139th, and China was at 187th place out of that 207. You can see in 1996, US was at the top, and India was around the 12th position at that time. Now, after that, lot of things changed within the next few decades. The early 2000s saw a sudden increase in the number of publications. In the 2010s, the growth continued with the number of publications reaching almost 1.5 million by 2014. And by 2020, the total of scientific publications had surged to around 3 million articles. So it was a significant increase compared to the previous decades. So this is the growth curve of the publications by country. I think the colors are visible here. You can see again the growth has been actually much more from countries like India and China than the developed countries. This is the growth of scientific publications by discipline. We can see the medical sciences actually have been topping the number in the growth. So during 1996 to 2024, there has been several times increase in the number of publications. The rate of these developed countries has actually stabilized and is much smaller than the growth rate in some of the developing countries, particularly India, China, Middle East. For the US, the growth has been around two times. For UK, it has been 2.7 times. Japan's growth had been 1.5 times. China grew almost by around 40 times. India also grew at around 16.3 times. So the factors that are said to have influenced this growth, number one is the technological advancements, the proliferation of the digital platforms that has made dissemination of research findings much easier. Increased funding. Many countries have invested heavily in research and development, leading to more papers and more publications. There had been global challenges also that has actually helped in getting number of articles even more. COVID-19 has been, for example, a big issue in which a lot of publications were made in medical sciences. Now we come to last 2024. You can see how the difference has happened. Now USA has been replaced by China as the country which gives us the maximum number of scientific articles. India is third, so India has also gone very high in terms of number of publications. Again, the same indicators, the countries by citable documents, again remains third, with China and US being the number 1 and number 2. Now, countries by number of sites per document, here again, the not so popular countries come in the first list. Now, UK was ranking 66th, China was 67th, USA has slipped to 124, and India has remained somewhat in the 135. It was 134, 35, that position which it was in the year 1996. So the issue is that we had been publishing a good number of papers, but if we look at perhaps the quality, then we need to kind of look into the quality of research that we are publishing, because we need to increase, although all these indicators all have their own limitations, but still if we have to go by these indicators, some improvement is required to keep pace with the growth in the number of research articles that have been published. This is by H index. H index also India is third, so if that is an index that is to be taken, it is also not that bad in terms of the pace in which the publications are being made. Now this is the quality of publications by subject, and we can see in the medicine and medical field, the publication, the quality and the number both are actually much higher for the medical fields than for any other field. So once we are talking about, so we are at the kind of prime areas where most of the documents are coming from. So therefore, this kind of workshop is extremely important for us to see that the quality and quantity both are taken forward as India rightly should. This is within the medical and the allied subjects. You can see again medicine being the biggest circle, so the largest one is from the medicine, and then there are various small offshoots of that, but they are of much smaller dimensions. And then we have the agricultural sciences, the biochemistry, genetics, molecular biology. So that is how the spread looks like. So this is the curve showing the evaluation of the total number of articles published per year and per publisher. You can see the top one is for Elsevier, the red one is for Springer Nature. You can see a very big jump from MDPI and Frontiers. So these two publication houses have actually shot up their number of publications in recent years. So this is something which you can take note of, and if you had been following news, then you would see that many of the papers that have been published in MDPI and even in Frontiers have been retracted, and there had been a lot of controversies that had happened with these publications. So what it shows is that number comes with some limitations and something that you must always consider vital, because quality is something which we should not compromise upon. In the morning lecture, Pratap sir had showed about the publications number with IISc, perhaps that shows how you need to be consistent with both your number and the qualities. So these are again things which actually point to the same thing. I am not going into the publication process because these are things that you know, and I will not waste your time much. I will leave the presentation so that you can see whenever you have some time and if you require anything on that. So these are some of the roles of the editor-in-chief and all. We have Dr. Samiran Panda here with us, so I should not be speaking on all this. In fact, I did a mistake by keeping my subject in this same topic where people like Dr. Samiran Panda and Professor Tharian is here. But anyway, I am only to blame for it. But anyway, so what I am trying to do is that I will skip some of these slides, and these are all a little bit more about the roles and responsibilities of the reviewers and peer reviewers who do methodical checks done by mostly 2 or more reviewers. And normally they are not paid. Again, I said normally because there are now new things which are coming up. On an average, 30% or more papers are reviewed than published. So this is the role of the publisher. So the editorial management, the business management, the production and online hosting, sales and marketing. Again, this landscape is also changing over the last few decades. So they are subjects of a different talk perhaps. But we as authors or we as scientists are trying to get into that system and plan our applications accordingly. So manuscript writing I will be skipping because you have a separate lecture on that. This is one of the slides that I generally like to tell to everybody, is that I view producing every paper like producing a product, a creative product like a movie. So we have screenings, we have edits, we have deadlines for the release of the product. I am not always the director of the movie. That might be me or it could be one of my students, but I am always a producer. The producer needs to push everybody so that the movie can be released on time. So the author is just like the producer. So you have to keep that in mind whenever you are doing your research. I will skip these. The different kinds of manuscripts, again, it will come in your paper writing. Most of the time, groundbreaking research are published in very good journals. You can see Newton here discovering gravity. The apple had fallen and it discovered gravity. And what we do most of the time is that we discover that oranges also follow the law of gravity. So many times when we do review of PhD research and all, they say somebody had done it in Kolhapur. It was not done in Pune. Somebody did it in Mumbai. It was not done in Chennai. So if there is no substantial change in the population and the study subjects or whatever, then you are likely to come up with the same result. So does it worth your time, efforts, and money? So these are things that we must keep considering whenever we are planning our research. Submission process also I will skip. Another thing I would add, we often get rejections for our papers. And it is always said that don't take rejections as a negative thing. It is always very positive. Try to address the comments that have been given by the reviewers. They have also spent time reading your article. And I would quote my former director, Dr. Kholkute, who used to tell that if rejection was the end of the world, we would never get married. So, so that is one of the favorite quotes that I have about rejections. So I'll come to the challenges. Number one is high competition and rejection rates. This has increased, and as we have seen, the number of publications have also increased. Technology has come. Now papers are very easily processed through the digital platform, so naturally the turnaround time has reduced, the bulk has increased, but the rejection rates also have increased. Top tier journals receive more submissions than they can publish, and it impacts even high quality papers that may be rejected due to space or scope limitations. There is pressure to publish, the publish or perish rule that we have. That is also something which we need to consider, to what extent we actually put mandatory number of publications for certain things, promotions, PhD thesis submissions. So because that also sometimes lead to problems. Of course, the biggest problem perhaps is with the predatory journals, how to identify them. I will have a detailed slides about a couple of these problems that we have. The peer review delays that happen, bias is again certain things that happen with some of the journals as well. We often face now the problems of payment of article processing charges, because these have shot up enormously and for good journals. So how to get these charges met? And sometimes we compromise with the quality. If our research is good, it would have been perhaps accepted in a better journal, but because they have a high article processing charges, we tend to give it to somewhat lesser known journals just because we don't have that money to pay for that journal, even if that research quality is very good. So these are things that actually plague us in every day. Publishing in interdisciplinary sciences, or I work in integrative medicine, it is very difficult because the best of research journals which are available in traditional medicine has got an impact factor of around 4.5. I don't have any journal in the world which has got an impact factor more than that. So my colleagues doing the same, giving the same efforts, are publishing in Lancet, and I am publishing in a journal which is an impact factor of 4.5. So these are issues that happen discipline to discipline, problems with your publications. None of the Ayush journals from India have any impact factor more than 1.5 or 2. So these are problems. Ethical and regulatory hurdles. There are several problems that happen. Ethics committees are sometimes too lenient, or sometimes they are so stringent that it is very difficult to satisfy the committees. So getting a balanced and professional ethics committees are also very important. I think Dr. Saurav will be speaking about ethics tomorrow. Language and formatting barriers that we always face. None of our English normally are, none of us are normally English speaking people. So we have difficulties in making people understand. And therefore, most of the time our papers get rejected is because of bad English. But nowadays, a lot of services are available. Now even AI actually will make your language so good, but then again, bringing AI itself will be a different subject of discussion, because again, that will relate to your plagiarism, use of AI. That itself, we do not have any solution on how to address the use of AI in scientific journals. Data sharing and reproducibility demands. So how the journals expect the data to be present or given, be it in public domain, or who owns the data. So those are kind of issues that happen, and it requires technical expertise and infrastructure to address those issues. And most of the time, limited recognition for negative or null results. We do not see many papers which has negative results. As I said, we work in traditional medicine. I am yet to find a medicinal plant which has been used and it has not been found to have any activity. So most of the plants, people publish and publish and publish. This plant has got this activity. Now to actually sieve them through and to get actual good evidence on what has been properly researched with becomes very, very difficult. So these are difficult problems that we have to go with. UGC had at some time the 2-paper problem. So before submission of the PhD thesis, now 6 months according to UGC only is the mandatory your training period, all the coursework that you need to do. And the PhD course is about 3 years time officially. And the last 6 months goes in your writing and all these things. So you are left with 1.5 years of your actual work. And if you do good research, you will minimum require 1 year's work to write a paper or something, and then you have to wait for the paper to get reviewed. It is just not possible to complete 2 good papers published in good journals within that time, unless you have an extended PhD time. Now, if you extend the PhD time and if the guide insists that you publish, is a good study that you have done, publish in a good journal, you may say the guide is harassing me. So these are kind of problems that come. So these have to be circumvented and some solutions have to be found about that. The article processing charges I just talked about, so this also is a big problem. 800 rupees book, that is what written in that cover. And this is the parts of those, the tribes of Karnataka. That section has actually contained the same kind of matter that we had in that paper. But interestingly, you see the first edition is 2014. If you can see the date here, first edition is 2014. When was my article published? In 2015. So who has plagiarized? So I have plagiarized. So then I was in real shock, what is happening? And normally, sometimes most of the papers would be written by the students and then I would be checking it and all. But this was something which I myself had written, so I know that it was not plagiarized. So I was really shocked. So, but then, so this was the first page of it. I did not have the book. So what I did is that I immediately do search for this particular book. And there I see in the search that first publishing, again, Abhijit Publications is fine, but there it is written 2017. So I went ahead and I went to Amazon. And in Amazon, I find it is selling for $27. And then there are other agencies also which are selling this kind of book, and sometimes prices even 2,000 rupees for this particular book. But everywhere, the date was 2017, so that gave me some kind of relief that at least I can show it is after my publication. So what I did is that I went on Amazon and purchased that book myself. So let me see and study that book, what happens with it. So I got that book purchased, and in that book, you can see that in chapter 1 itself, the photograph that is there, it has got that date stamped on that photograph. And that date shows 14/4/2015. So that shows that the publication must have happened after 14/4/2015. Now when was my publication made? Again 2015. Now it comes which month it was published. Then I started thinking whether the editor who had actually done not the editor, the reviewer who I might have reviewed my paper, whether he was the person, he or she was the person who has published this book, taking those things or not, so I don't know. At that time, I contacted IJMR. Sir's predecessor was there as the editor-in-chief. So at that time, I contacted her, and then I told the full story that I'm really confused. I want to know and want to go deep into it, what has happened and all. But they did not have the records of the person who had actually reviewed it. But what happened is then I wrote to the ISBN, which comes under the MHRD, quoting that number. Now I have bought that book in Amazon, so the ISBN number I quoted and wrote them that I wanted to know the authenticity of this number, Forest of Karnataka, published by Abhijit Publications, and the year of publication. So they wrote back to me, the ISBN quoted is not valid. So that means these ISBN numbers are also all scams going on here and there. Who checks those numbers? So, so that helped us, and then later on, again we got contacted with the Bangalore University from where it came. So they knew it has been plagiarized, so they wanted us to take action against the person who had actually published that book. I informed this to the editor of IJMR, because it was IJMR's paper which was plagiarized, and IJMR wrote to Abhijit Publications asking for explanation. All they had sent around 3 reminders, nothing has happened. They tried to call them on the phone number, a mobile number was given in their in the publisher's site. That went unanswered, and then we also did not pursue it, and IJMR also did not pursue it. But that is how things happened. So that is one case which we had faced ourselves. The third one was, it is a very good journal, Onco-Target, which was published in 2016 on glucuronidase, which actually sensitizes KB cells along with paclitaxel. So it enhances the efficacy of cancer chemotherapy. So it was a good research work. But what had happened is, with one of the photographs that was given in that paper. So here you can see 2 of the smaller photographs inside, which are marked with the red one. So they are actually almost the same repeat of that. So again, here also they are the same. So there were questions asked to the editor, and then what we found is that in the uploaded ahead of print version, everything was fine. But when actually the print version came, somehow that it got repeated or whatever. So it was something that happened in the publication process, not actually. Thankfully, we had the ahead of print version with us. So we showed that to the editor, and then it was found it was a genuine printing mistake that had happened during the printing process. So similarly, there are so many incidences that happen. Now it is predatory collaborations also. People send emails. If you, mostly things will come from China. If you have an idea, please give this idea and whatever and all, you will get this many. We will call you for a conference in Beijing and all. They will basically steal your idea. So be very careful while you are good idea. Ensure that they are taken properly into channel. Just don't leave things to unknown people and unknown editors or unknown journals with your ideas. Again, these are kind of techniques in which our ideas get stolen by even foreign countries. There are some other things as well. So what I just told you is that the paths to publications are full of a lot of challenges which we have to overcome. But this is the only route that we have to take the benefits of research for the people. And I wish that with all the efforts of our colleagues, we will be able to instill some of the knowledge and some of the awareness that we wanted to bring to you. And as our secretary, DG sir, had said in the morning, so you will only learn something, but unless you actually do them in practice, the learning will be incomplete. Thank you. Thank you very much.
Thank you so much, sir, for your highly informative session and very practical issues and challenges that you have highlighted on publishing papers. Thank you so much, sir, once again. So Yeah, we would like to felicitate sir with the Gamasa and hand over a small token of our love and appreciation as a gift. So I would like to request Dr. Saurabh Padgiri sir to kindly come over and hand over the gift to sir. Thank you so much, sir. So before we call it a day, I would like to make a couple of announcements. So I would like to remind once again that we will have a live musical concert at the backyard, just behind the reception building. So it will start at 7 p.m. onwards. So on my watch, the time is 5:30, so we have around roughly 1.5 hours to get freshened up. So we'll come back at the backyard at 7 o'clock for the live music concert. And then dinner will be served here at 7:30 p.m. onwards. And tomorrow, tomorrow we will begin our session by 9:30 a.m. sharp. I would like to announce that all the resource persons for tomorrow are here already. So we are very fortunate because all the resource persons are highly eminent people in their own field. And to have them, not only for their session, but to help them the whole day from morning today and tomorrow. So we are highly fortunate that they are here with us. So let's make the most out of it. So tomorrow, let's all make it a collective effort and responsibility to come by time at 9:30 so that we can finish by time. So today's dinner will include the scientists and staff of RMRC as well. So you are all kindly requested to stay back. So with this, we'll call it a day. Thank you so much. Have a good evening. Thank you. Another thing, like those who have not submitted, participants, those who have not submitted their TADA reimbursement, our account teams are here, so kindly submit today or tomorrow morning by first half. Thank you so much.